and Sumathi for inviting me to be part of this session. My only regret is that I'm also part of the SCID session down the hall, and so I kind of am missing out on a lot of good things here and a lot of good things there. But anyway, so what I was asked to do is talk about long-term outcomes following transplant for Wiskott-Aldrich. These are my disclosures. I have no conflicts of interest. I wanted to start by telling you about the Primary Immune Deficiency Treatment Consortium, or PIDTC, and this is really what it is. This is from our meeting that we had just last month. It was our 7th annual workshop, and these are all the scientists and physicians, transplanters, immunologists that are taking care of patients with SCID, with Wiskott-Aldrich, and with chronic granulomatous disease. And we really represent, it's 44 centers in the US and Canada. There's just a map, shows where all the centers are. I'm not going to spend time going through all of that. And we're basically funded by the National Institutes of Health. We're part of what's called the Rare Disease Clinical Research Network. And our funding started in 2009. And again, as I said, the focus is on severe combined immunodeficiency, Wiskott-Aldrich syndrome, and chronic granulomatous disease. What we're doing for Wiskott-Aldrich is right now a retrospective study. Well, it's actually retrospective, prospective. We're kind of taking all patients, but retrospectively, at least, patients who got transplanted since 1990. And as I said, there's a prospective component, and then also what we call cross-sectional, where we're asking patients who are more than 2 years post their transplant to come in to the clinic to have an assessment done of how they're doing and get certain laboratory tests to see what the state of the transplant is. Some of the research questions that we're trying to answer, which I don't have for you today, is 100% donor engraftment. Do you need nearly full donor engraftment to completely correct Wiskott-Aldrich syndrome, all of the manifestations? And I'll show you data that other people have published that support that to some extent. What are the long-term outcomes, including the late effects of transplant for Wiskott-Aldrich? Again, I'll show you data from other studies. What is the quality of life for patients and families? This includes siblings of children with Wiskott-Aldrich, because I think it's something, I suppose, as scientists or clinicians, we tend to lose our focus on, because we're so interested in exactly how the patient is doing clinically. But there's a big psychological component that I think we need to spend more time on and focus on. And then the big issue I think many people have, a big major question, is autoimmune disease, not only pre-transplant but post-transplant, and trying to understand what the biology is of that. So we're also studying that. So, for people who are, want to follow the PIDTC, want to know what some of our results are as they come out, want to be more involved with us, then there are a couple of ways you can stay connected. I actually had to join Facebook. My group made me do that so I could see the Facebook page that we have. But we also have a registry, the Rare Disease Clinical Research Network, where on their website is it's a contact registry for patients, and you can sign up on that registry. I did it last night. It's very easy. All you have to do is Google RDCRN, and what you'll get is, and then you can see the RDCRN contact registry, and just click on that, and then under how to join, just type WIS, It's not Wisconsin, it's Wiskott-Aldrich will come up. And just basically click on the link in the blue box and you can join, and they'll consent you. And then, you know, what do you get from that? You'll get our newsletters, you'll get any information that, you know, we're putting out in terms of publications and so forth. So, you know, and also oh, okay. And then also, if you stop by the exhibition hall, we have a booth, and we have two of our project managers, Tara and Megan, you can talk to, and there's also brochures and stuff, so you can even get that information there. Anyway, okay, what about long-term outcomes? So the studies that really tell us about long-term outcomes after transplant for Wiskott-Aldrich syndrome are really limited. You probably have heard that before, but they're mostly what we learn about it is from small single center reports that focus mostly on overall survival. You know, is a patient alive, is a patient dead, but not really what happened to that patient or what is happening to that patient right now. So long-term outcomes I'm sort of interpreting as well as late effects. And I think it includes late effects. And these would be the patient's clinical and laboratory, what the patient's clinical and laboratory status is years post-transplant. And for most people looking at late effects for whatever disease, at least for the primary immune deficiencies, they tend to look at greater than 2 years post-transplant. And the reason is probably maybe obvious, is that most of the deaths that occur because of the transplant occur usually within a year or two. So beyond 2 years, that's usually when you can start asking, you know, what are the sort of long-term outcomes or late effects. And really there are two sort of, not definitions, but two characteristics of this. One is these could be underlying disease manifestations not correctable or maybe incompletely corrected by the transplant, or they're complications of the transplant, like chronic graft versus host disease or immune dysregulation or chemotherapy toxicity. So this is the one study that I found that really focused on late effects and long-term outcomes. This is only patients who survived more than 2 years, and it was from the European Society of Immunodeficiency and the European Blood and Marrow Transplant group. And so they put together 97 patients with Wiskott-Aldrich syndrome between 1979 and 2001. 93 were alive beyond 2 years at that 2-year time point. So, hey, that's great. The overall survival is 97%. So, I mean, and that's really good. And that is what a lot of centers focus on. You know, have we kept the patient alive? And the follow-up was anywhere from 2 to as long as 25 years post-transplant. The event-free survival, however, was only 75%. That still is pretty good, but it's a lot less than the overall survival. So what is event-free survival? Well, they define certain things that are called events that kind of indicate that the transplant failed, at least to some degree. Death is certainly an absolute failure, so there's no degree there. That's it. But chronic graft versus host disease, getting a second transplant, requiring a splenectomy post-transplant, having eczema that lasted more than 2 years post-transplant, the presence of autoimmunity, inflammation, or allergy beyond 2 years post-transplant, infection post-transplant, mostly viral infections, and then what they call disease and transplant-related sequelae. These could be malignancy, chronic lung disease, and then what I've highlighted here at the bottom, let's see, does this work? Yeah. is that sterility, growth retardation, developmental abnormalities, these weren't addressed. These weren't considered, not that they weren't considered, but they didn't have data on them to include them in this. So we don't really know about those factors. So what did they find? Well, autoimmune disease, as you might expect, as many of you know, was a big thing beyond 2 years. So 20% of the patients had some type of autoimmune manifestation beyond 2 years after transplant. Most of them were low platelet counts or white count or red cell count, thought to be autoimmune, but there was also vasculitis, inflammation of the blood vessels, mostly in the skin and the central nervous system, inflammatory bowel disease, hypothyroidism, adrenal insufficiency. These were all things that were categorized under autoimmune disease. And then they found that 40% of the patients who had pre-transplant autoimmune disease, it persisted post-transplant. So that was another thing that I thought was interesting. Another big thing was 6% of the patients continued to have infections post-transplant. Interestingly, this was all related to patients who had had a splenectomy. So that was definitely a risk factor going into transplant. Eczema is not a big issue. Only 2 patients had persistent eczema post-transplant, and none of the patients developed cancer, at least in the follow-up period that they had. And then they found that percent of donor engraftment, so the percent of cells that were from the donor in the blood, was a major factor in the overall determination of event-free survival. So there's another study that was rather a big study, retrospective study, and an international study. 12 centers contributed patients. It's 194 patients, and it went from 1980 to 2009. It's a little complicated because some of the patients from the first study I mentioned were included in the second study, so they're not independent of each other. And they really didn't, that was the focus of the study was not necessarily long-term outcomes, but they did look at 135 of the patients who had survived and were beyond 2 years post-transplant. Now, don't say, I don't want you to look at this and say, oh, 135 divided by 194 is it's not a good survival rate. But you can't do that because they excluded patients who were still within a 2-year time point. They were still alive and they're being followed, so you really can't determine the survival that way. But the important point is that 29% of them had active problems or had died beyond 2 years, giving an event-free survival of around 80%. So it's pretty similar to what had been found by in the previous study. And the biggies were thrombocytopenia and autoimmunity beyond 2 years post-transplant. 14 of 36 patients had thrombocytopenia with platelets less than 50,000. So pretty severe thrombocytopenia. And they found that the degree of donor engraftment, we call it chimerism, correlated or was very important in terms of long-term outcome. So there were 92 patients who survived beyond 2 years, and they had good chimerism data. So now we're narrowing it down into this group. And they found that if there was greater than 50% donor neutrophil engraftment or myeloid engraftment, white cell engraftment, those patients were much more likely to have normal platelet counts. And if there was less than 50% B cell engraftment, okay, or neutrophil engraftment, those patients were more likely. That was in the patient group that had autoimmunity, more likely. So it starts to give you a sense of what the standards might be for what you want to achieve in order to, correct the thrombocytopenia and prevent the autoimmunity post-transplant. It does suggest you need high chimerism for Wiskott-Aldrich. How high? These are some guidelines, but I don't think we really know for sure. And the numbers are relatively small, so I think we need more data on that. Malignancies, I'll go quickly now. There are no specific studies about cancer after transplant in Wiskott-Aldrich. This was a study from the Center for International Blood and Marrow Transplant. It's a group that gets data from virtually every center around the world, transplant centers, so it's pretty big, and it's all retrospective and so forth. But they looked at all kids with primary immune deficiencies between 1968 and 2003. There were over 2,200 patients, and 360 of the patients had Wiskott-Aldrich syndrome. So that actually turns out to be a pretty good number. If you just looked at all of those patients and looked at the incidence of cancer at 15 years post-transplant, there were 52 cancers. Actually, I'm getting it's either 10 or 15 years, but it's long-term follow-up. And 2% of all patients, that was the risk of getting an incidence of getting a cancer by 10 years. For Wiskott-Aldrich, it was 4%. So it's relatively small, but it's still significant. So there still remains a risk. Now, is it due to the underlying Wiskott-Aldrich that wasn't corrected, or is it because of the chemotherapy that was given? We don't really know. We do know that that most of the side effects, like cancer, seem to be more related to things like radiation versus chemotherapy when you compare the two. But chemotherapy certainly can be responsible. But if you look at the 52 cancers and the 12 cancers that were in the WASP patients, there were 5 that were due to lymphoproliferative disease, some that had EBV, some that didn't. We see this post-transplant in many other diseases. So, is this because of WASP, or is this because that it was transplant related? I tend to think maybe it's more transplant related. But the lymphomas, the leukemias, I would start to think maybe that's could be the underlying risk from WASP. What's that? Yeah, that's true. This study did not go that deep into this. We don't know. So anyway, I think it's there. What about other late effects that really we haven't addressed much? Well, growth and development, things like the brain, tooth development, endocrine, and so forth. These things haven't really been addressed in much. Sterility, I know, is a big issue, and it is a question that we all have. Most of the studies, so there's nothing specific on WASP, but if you just look at studies in other, just in patients, most of them getting transplants for cancer, but so they may have been treated or likely have been treated with other chemotherapy agents. So it's kind of difficult to sort that out, frankly. And most of the studies were in patients getting busulfan and cyclophosphamide, which we know has a significant impact on sterility, or influence on sterility. But it does appear, and this is mostly just kind of individual experiences from centers, there's no big study yet that I know of, but that fludarabine, which has been now used to replace the cyclophosphamide, and so either busulfan fludarabine or melphalan fludarabine, which are two of the more common regimens that centers are using for transplant for Wiskott-Aldrich, appear to be less toxic, but to what degree, I don't know. I know that there are more and more cases of patients having been exposed to these regimens who subsequently conceive a baby. it's, we think that it's going to be less definite than with, say, radiation regimens or busulfan Cytoxin regimens, but we just don't know. Is storage of testicular or ovarian tissue effective? I think that there has been at least one report of it being effective, that is, of ovarian tissue being thawed and then subsequently used to conceive a child. But it's still, I think, experimental in many respects. We don't know for sure. So, as I said, in large studies of patients with leukemia, radiation is the biggest culprit when you compare it to chemotherapy, but it doesn't let chemotherapy off the hook by any means. And I think the two things, again, I started out by saying this, and I'll just say it again. I think the psychological effects on the family, and the term post-traumatic stress disorder has been shown to be part of transplant in families. So we showed this many, many years ago, and I think other people have confirmed that. And I think that's something that needs to be focused on, and quality of life again. And we'll hear more about that the next speaker. So I just want to end by saying in terms of what the PIDTC is doing, again, I have no data, but we are looking at patients transplanted since 1990, including Wiskott as well as XLT. By the end of August of this year, our goal is to enroll 291 patients. We've already enrolled 246, and we have an interim analysis planned on 131 patients transplanted in the last 10 years. So I'm hoping that'll give us some at least early clues or hints as to what we're going to be looking at. And then we're doing the special studies to understand autoimmunity, and we're also doing, or have done, and in the process of looking at a joint international study of quality of life and family impact of having Wiskott-Aldrich. And that's in collaboration with the Wiskott-Aldrich Foundation, the IDF, and the Israeli Wiskott-Aldrich Association. So in summary, I think there's a significant incidence of late outcomes or late effects in Wiskott-Aldrich post-transplant. Donor type is a factor. I didn't really have time to get into that, but alternative donors, and probably in terms of needing a second transplant, and also graft versus host disease is where the impact would be there. Autoimmunity, including vasculitis and thrombocytopenia, are common late effects. Chronic GVHD and infections also play a role. Malignancy seems to be uncommon, but I think we can't forget about it, and patients need to be followed for a long time, maybe forever. Eczema seems to resolve. I didn't see any mention of food allergies, although that in our patient population, we see a lot of patients with terrible food allergies, and they do seem to resolve by 2 years, so maybe that's why it's not mentioned very much. But sterility hasn't been tested. Growth and development is really not specifically addressed in these studies. And then the biggest issue is that it seems to be related to the degree of engraftment. So, I would say, greater than 80% donor chimerism appears to be critical, but I think we don't know for sure. And I was interested, I only heard the last discussion on gene therapy yesterday, but I wonder about that too, in terms of, and I think it's something that we'll have to learn more about after gene therapy. To what degree do you need correction in order to, or do you need engraftment of gene-corrected cells in order to eliminate the autoimmune manifestations? Thank you.
part of your summary did not include age at time of transplant. Was that a factor at all? Because being a teenager, University of Michigan did his transplant, and I thought they did a phenomenal job, even though he was only the second Wiskott that they transplanted, and his team was phenomenal. However, we still have a 34-year-old, 16-year-old living with us.
No, that's a great point, and I probably should have mentioned it. The age it appears to be a factor, at least in some studies, and it certainly suggests that the earlier you do the transplant, the more likely you are to have fewer late effects. I mean, that's kind of the theme. How early? Because now you're talking about giving chemotherapy. So the earlier you give, it's very complicated. So, if you give chemotherapy early enough, you'll also have potentially greater effects on, ability to have children and growth and development and so forth.
However, he will never have a serious relationship. He's had DUIs, he can't hold bank account. He is a carpenter. Yeah. He can focus on one thing at a time. We have our own building business, our own real estate business, but his brother, who has Wiskott-Aldrich, is his boss. And when he gives him a task on a job site, he has to write it down. He can't verbally say, I want you to go to the job site this, job site this, job site this, do this, this, this. He has to write it down. He can't use a mom. He can't listen to me. He can't do what I ask him to do. But he can build a deck for you in a day. I mean, he can do that. And so it's almost like he had autism or, definitely ADHD, which he did. He was very high IQ kid going in. But now he is not. And now, he may have the IQ, but he cannot function like he did before. Like I said, he's probably will live with us until we die. And he will probably, he texted us the other day, my brother from Texas to come in and take care of his dad. And he's going to stay at my house. So like, Josh, you have to clean this, you have to do this. And he took over our clothing for my husband who was here. My husband just had to fly home this morning because he's falling apart. I can't do this and this. Like, Josh, you have to be the adult now. You have to handle this. And he said, I can't handle this clothing for him, and I can't do this. Yes, you can. It's like talking to a child. Yeah. And this is what, he already had a stroke. So I saw his brain scan. He does have brain matter on his brain. And the neurologist said the chemo, the cytokine that he had, did close off his further development of his brain. So we can't coulda, woulda, shoulda. We could never go back. But we took what we had at that time, and we were trying to make that decision. But
yeah, I think you're raising very important points, and I think we need to know more about that. We need to know to what extent it affects.
We used his brother as a donor, but we couldn't tell the other brother, we're only here to fix your brother, we're not to fix you. We couldn't do that to him, and that's one of the way they were. So, like I said, we can't look back, and we have to have, but I really think that if people are, making that decision, they have the option to go sooner rather than later. The only thing I could say is you have the ability to think externally.
Yeah, again, we certainly have learned a lot in the last 10 years in terms of how to administer chemotherapy and, how to do it much more safely. And, whether, it's hard to specifically, answer, your issues, but, you raise good points.
Hi, Dr. Cowan. I don't know if you remember me, but I brought my son William to you when he was about 2 years old when you diagnosed him. He's 25 now.
Oh my gosh.
He had the ARCH86 mutation. And there's been so much pressure from me over the years to have him transplanted. And
not for me.
I don't know. I just couldn't do it. PTSD thing with this.
think I should let Dr. Ox and Dr. Albert try to address that, because those are, those are just very difficult questions to answer, and I can understand what you've gone through trying to make those decisions. I mean, maybe, yeah. I was going to say, maybe gene therapy, where you're using only his own cells, would be, some kind of option to think about. Although, we're still having to give very high doses of chemotherapy for that. So we're no. That's the easy. I mean, I think eventually, I think we will be able to do that, but it's only been in the last few years, or maybe even in the last 5 years, or maybe 10 at the most, that people have been really aware of what we call pharmacokinetics of busulfan. And I mean, we knew, we've known for years that adults sort of get higher, they do, that if you give a dose to an adult, they're going to get a higher level of busulfan than in a kid. But we never really understood until more recently how that really changes, especially in the first decade of life, and how it varies from one kid to the next. So we don't have any of the studies that have been published now really don't have any of that information.
Well, how do you choose the drug? Why this drug, not the other?
Yeah. You try to choose drugs that will specifically do what you want them to do. Why does one center use melphalan fludarabine, another center uses busulfan fludarabine? It's what they, right now it's what they feel comfortable with. There's never been a study that has compared one to the other. Now there's triosulfan. There's other drugs that are coming out, but at this point in time, it's almost a religion. And which church do you want to go to? Do you want to go to the busulfan church, the triosulfan church, the melphalan church? Well, there is a rationale. I mean, and I don't mean to put any of us down as transplanters. But we like to use busulfan because we can measure what a kid's getting, and we can target specifically what that child is going to see in terms of the drug. So we feel much better and comfortable using it. Melphalan, we're doing that now. We're just starting that, but nobody else is doing that right now. But eventually, people will be measuring melphalan. Fludarabine, we've done that too, and we'll be starting to do that at our center, and I think it'll happen at other centers. But the field hasn't gotten there yet. But it will. It's personalized medicine, and that is what's going to happen. But until we have that information, I'm not sure we can answer your question, which is a great question. Yeah. Not at this point. I think we'd have to see more data. I think I did hear the part towards the end of the report on that gene therapy, and I think it was 8 patients, right? That were, so you know, if I told you about 8 transplant patients, everybody would be yelling at me like that's just not enough, you know, to really make a decision. So, I mean, we have to apply the same criteria. So I think, and we'll have to see patients that got rituximab, patients didn't get rituximab, or, you know, or if there's, you know, maybe next year we'll hear that there's been 25 patients that all got rituximab and none of them have autoimmune disease post gene therapy. I mean, then that'll be something that'll be really important to look at. I mean, the conceptually using rituximab makes sense, but I think, you know, it's something that it has potential side effects too. So it's not, none of these things are benign. So I better run. I'm sorry.
Thanks.
Did the splenectomy, which his platelets went up to a normal level. He was wrestling coach. He played football, soccer. He was a body weightlifter. He played guitar, piano. And I knew that I had to take care of him all the time, but once you grow up and you no longer have control over the activities that they do because they make the choices of what they want to do, even though you're against it. My son made the choice of doing sports. He loved sports. That was something I cannot take away from him. But I believe that the quality of life that he had, he wanted to live like a normal child. He did not want it to be pinpointed as being sick. As for the younger one, he had the splenectomy done at the age of 9 months. The splenectomy did not work on him. His platelets did drop. But he used to love to run, and he loved science and music. So it was two different cases of WAS. One had problems with his skin. The other one did not have any problems. But the infections that I was worried about them to get, it was pretty rare for them to get a very dangerous infection. So, you know, my point is that it's sometimes up to the parents, and you teach them all you can to take care of themselves, but ultimately they make the choice. And you kind of hope for them to make the right choice too.
Thank you. So we all know that Wiskott-Aldrich syndrome is a disorder that typically affects males. And we also know that, and this is because the WAS gene is on the X chromosome. And also typically we know that all the carriers are asymptomatic. And this is due to a preferential selection of the normal X chromosome as the active allele in the hematopoietic cells. So WAS is expressed only in hematopoietic cells, and the preferential selection of the normal WAS gene give a prevalence of normal cells in carrier females. Although that rare cases of affected Wiskott females have been described, and these are usually due to extremely skewed X chromosome inactivation. That means that we have something different than what is going on usually. So what is X chromosome inactivation is process by which the two X chromosome, during early stages of embryogenesis, got randomly inactivated in female cells. So at the end of the process, we will have some of the cells with one X active and some of the cells with the other one. And this will be at a rate of 50% if the process is normal. In some cases, and Wiskott is one of these, there is apparently a non-random X inactivation that is coming, when the gene is important for some function of a cell. So if the mutated gene is important for proliferation, for the cell growth or development of one of the subtypes of the cells, in these cells there is a preferential selection of the normal allele. Is there a way to check for that? Yes, for many years we checked that with this molecular technique. That's a way to understand which one of the two X chromosome is activated. And this has been used for years to know and to check for the carrier detection in many primary immunodeficiencies is X-linked. And in this way, we can also understand whether there was an importance of the gene in the different subtypes. So what we know from the X inactivation in the Wiskott patient in the Wiskott carrier was that the importance of WASP vary in different stages of the hematopoietic development, starting from the CD34 plus cells and going through all the other subtypes of the cells, of the hematopoietic cells. So human female carriers of WASP mutation are known to exhibit this non-random X chromosome inactivation of mutant WASP in peripheral hematopoietic cells, starting from the earlier progenitors, which are CD34 positive cells. Rare cases come from a difference in this, that is the imbalance of the X chromosome inactivation. But having said that, we wanted to check whether there was another way to see a difference in X chromosome inactivation. And we'd like to combine a more functional study with that. So if there's a way to predict which will be the story of the patient, knowing the mutation, or there is something that in some way correlate the mutation to a marker that we can check, and obviously yes, and you know from all the other talk in these days, we know that when we have a mutation in some site of the gene, and this mutation is kind of mutation with this, let's say, a missense mutation, so a mutation which can lead some protein expression, then we will have a milder phenotype. This is what we know. So protein expression is really important. The level of protein expression is really important. And how do we check that? We check protein expression by flow. You have heard before that you can do it by flow cytometry, or you can do it by Western. We choose flow because we think that with flow cytometry you can go deeply in different cell subtypes and we can understand all the difference, also tiny difference in protein expression. With this kind of test, if we check lymphocytes, this solid black is the amount of expression of the WASP protein in the patient, in the normal control, in the healthy donor. And the black one here is the one in a patient with intermittent thrombocytopenia. So if you check protein expression in a patient with a really mild form of the disease, you will find that his protein expression will be almost equal to the normal control. If you check the same in a patient with the intermediate form, so the XLT, you will find residual protein expression. If you check a patient with the most severe form of the disease, you will find no expression of the protein mostly. These are all the data summarized we have in the lab, so if you check them by clinical phenotype, you will have the great majority of reduced expression of the protein when you have an XLT phenotype, and you have the huge majority of the patient with the absent expression of the protein if you have a Wiskott severe phenotype. So starting from that, we know that the amount of expression is something that we can use and we can check in the patient. So we set up this combined multiparametric flow cytometry approach in which we decided to check at the same time the expression of WASP, which is an intracellular marker, and many surface staining for the different subtypes that we wanted to check. And these are for granulocytes, monocytes, NKB, and T cells, for dendritic cells, and also for CD34 positive cells. All of these can be done in a single tube and can be done in 3 hours' time. So in 3 hours' time, we can check all these different subpopulations, and the only thing that we cannot do in the same way is the CD34 positive cells, because they need a different procedure to be collected. So after this, we set up this procedure, and we use it at the beginning to check for the chimerism post-transplantation in Wiskott patients. And in this way, we can have the exact amount of engraftment in all the different subpopulations in a way which is much easier and quick than the molecular test that our lab used before. What can you see? You can see a first peak, which is the negative, so the cells which are of the, still of the patient, and you can see this other peak, which is the normal expression of the protein coming from the donor. So the rate between these two give you the amount of engraftment of the patient. So you see here we have done this with many different subpopulations, and the same was done, actually this is the detection power, and this is really important because this is not a PCR-based test, it's a test, a flow cytometric test, and so we can check as low as less than 1% residual cells, was positive or was negative. This was important also because this allows us to analyze some of these revertants. You have heard before that there can be revertant, and in Wiskott there are many of these cases, and this test gives you the possibility to check for this. But at the end, we like to use this test to check for carrier detection in females, because we thought that this could be the right way to check, to analyze the X chromosome inactivation, because we can see both the expression of the mutated X chromosome and of the normal one. So what happens in carrier is that you have, like in the chimeric patient after transplantation, you have the two different peaks. One with the WASP negative cells and the other one with the WASP positive cells. You see that this is a female, and the level of expression of the negative part is different among them. If we analyze all the 10 different subsets that we use to check, you can see that these peak, which is the negative peak of expression, change, you see, checking all the different subtypes. And in these cases, you will see only the peak of the son of this female carrier, which is exactly overlapped to the WASP minus cells of the female carrier. That means that every time you have a mutation, you have the same expression and you can compare them. And what was Dr. Aldrich saying before is that you cannot compare between different labs is absolutely correct. You have to do in the same lab with the same reagents in the same conditions. But this is a technique that you can use everywhere. In the same lab you can use. And you can go even further and analyze all the different subtypes of B cells, for example, or T cells, and go even deeper in this analysis of the subpopulation. So what come out from all these analyses? This has been done on almost 60 female carriers coming from, referred to our hospital. And what we see at the end is that in the Wiskott female carrier, this selective advantage of the normal X chromosome is really strong, especially, sorry, I cannot find, especially in the lymphoid cells. So starting from NK, B cells, T cells, almost all the cells express the normal chromosome. That means that for these cells, the normal, to be normal is really important. This is a comparison with what we found in another immunodeficiency, which is agammaglobulinemia. If you have a mutation in the BTK gene, you can have X chromosome inactivation, which can be apparently non-random in other subpopulations, but not in the ones which are important for the Wiskott female carriers. And you can see the difference here. So the wild-type allele, that is the normal allele, is present 50% of the time, while in Wiskott carrier is almost present 90% of the time. That is quite different. And if we see subtypes by subtypes, you can appreciate the difference between the myeloid cells, in which there is an average around 60% of expression of the normal allele, and lymphoid cells, which are going to almost 90% in CD8 positive cells. So this is something which seems to be and is related to the kind of mutation, because the more severe is the mutation, the more this apparent inactivation is pushed to the normal X expression. So has this something to do with the question that we have regarding the female carrier? That is, are female carrier with mutation in the WASP gene more prone to all the clinical complications that their son can have, and especially thrombocytopenia and autoimmunity and lymphomas or tumors? We found, now we are at 7 of these cases. These are cases which are in this part of the graph I showed you before. So the normality is up there, but some of the female carrier has an expression of the normal allele around 30%. These are now 7 cases, so we call them with inverted inactivation. So they have the non-random inactivation on the opposite way that it was supposed to be for the natural selection with for the WOS gene. In these 7 cases, we have all different kinds of mutations. We have whole different kind of clinical phenotype. So we have intermittent XLT and also severe Wiskott. We have deletion of the old gene, and we have really mild missense mutation. We have some expression, residual expression of the protein, and we have no expression of the protein. So we don't know what is changing this phenomenon. But all of them, all of these female carrier has thrombocytopenia or low platelet count, MPV, sorry. And they have some of these bleeding phenomenon, which are not really severe bleeding, but happens during their life. So starting from that, we decided to prepare a brief phone questionnaire that we wanted to all the female carrier in our hospital and refer to our hospital to complete, to check whether they have any of the clinical manifestation that we want to know are present or not. And are the 6 with inverted inactivation. And as you can see, 5 out of 6 has this petechiae or bleeding, and 4 has this heavy menstrual bleeding, they say. Platelet value is low in 5 out of 6, but the 6th woman has this low MPV. One of them has low hemoglobin value. None of them has any of other clinical manifestation, let's say autoimmunity or tumors. But if we go to the 37 carriers we have checked till now, numbers are increasing a little bit, and we have 6 more with bleeding, but we have understood that this is actually a quite general question, and we do not have any real clinical way to check whether this is a real bleeding or normal, something which can normally happen. And the same is for this menstrual bleeding. We don't know. It's also up to the subject, or it's something that we do not have something which is really objective to say whether is that the case or not. What is objective is platelet value, and platelet value is below normal only in 1 female more than the one with the inverted X chromosome inactivation. So this happens only once. And this once was during pregnancy. I don't know whether this could have any importance or not, but this is the only case in which we have a platelet value which is below. What else? Autoimmune disorders, or we have 2 thyroiditis, 2 arthritis, and 1 diabetes, and this upper respiratory tract infection severe, and 2 thyroid tumors and 1 breast cancer. What is there any importance in this data? We don't know. Numbers are too few for sure. We need to increase absolutely the number of carriers. Thyroid cancer, 2 out of 36 is something that we need to think about because it's not a normal incidence. But for sure we will need to increase the number, and I hope that many other hospitals will join this kind of brief questionnaire and just to understand whether it's the case to go deeper or not into this information. Regarding the autoimmunity, Fabio yesterday showed you this, a part of this work that was just on the patient, but we have done something also on carrier females. And as you remember yesterday, the patient has an increased number of autoantibodies as checked by this autoantibody array, which is something that clinical immunologists doesn't like that much because they doesn't trust this kind of results as something which is reliable and need for sure to be checked later on and to see whether this has something to do from the clinical point of view. But carrier females are for sure different from the healthy donor, which you can see here as nothing in terms of autoantibodies. That is, this is something else we have to check with the time, over the time, and to see whether there is something to be done. So, in conclusion, we can say that the X inactivation is heterogeneous and can influence directly the rate of inactivation of myeloid cells, which give you the rate of platelets, and so control, which is the kind of platelets that are produced by these carriers. Normally, the rate is skewed at the level of lymphocyte subset due to the selective pressure, and this is more effective on the cells of the adaptive immunity and with mutation which are associated with the more severe phenotype, that means with less expression of the protein. The preferential inactivation of the X chromosome, which carry the normal WASP gene at the level of precursors, should not be underestimated because in our numbers is around 10% of the carriers. And every time we have this inversion, we have a platelet problem. So this is something we have to check for. So which are the difficulties to check or to analyze and to have a complete carrier studies like the one we have tried to do is first of all to have all the information. It's difficult to have the information from the clinicians because their attention is focused on the son for sure, but we think that if every time there's a new diagnosis, there will be a check by flow of the X chromosome inactivation of the mother. We will have immediately some important information, and this is what we routinely do. So every time we check mother and son together. And also that many carriers without the affected son are not really collaborative on that. And these are a huge number of persons that can give information about that. So what remain open questions now? Why some of the carriers have this inversion of the inactivation? We don't know which drive this process in that way. We know that we can check it. We know that we can now, after understand that there is an inversion, we can follow the lady and give support on that, but we don't know why this happens. We know that when it happens for all the life. Is longitudinally, we follow them, and is something that comes really from the beginning of the X inactivation process. Should the X chromosome inactivation be a useful test? We think yes, that it has to be done and can give you this important information, and could also change the policy of the carrier analysis. Because let's say in Italy we cannot do carrier analysis since they will be 18 years old. But one of the 7 females I showed you before is 9 years old. So if you check X chromosome inactivation and you see this reversion of the phenotype, you can immediately follow for that. Is there a correlation between the high autoantibody present in the study and autoimmune manifestation? We don't know. We cannot make any correlation because all the females we have checked has high autoantibodies, and only few of them has some manifestation, so we really don't know. And at the end, really only a bigger study on that with many females enrolled can give some important results. And I will thank the people involved in this study. And if I have 2 minutes more, I will go through the question. The question that you write down on the paper. So how common is it for carrier to have low platelets? In our experience, is around 10%, and is always linked to an imbalance of the X chromosome inactivation. How low do they normally go? We have the baby, the baby. She is 9 years old. She is around 40,000, and usually they are around 90,000. Does it vary with age? No. And do they have issue with bleeds? Minor issue, not really a big issue for what we have in our experience now. Is there an increased incidence of autoimmune disorder, malignancy in carriers? We don't know. We need much more numbers. And what kind of disorders we have seen? We have 2 thyroid tumors, and we have thyroiditis, and not much more. Do carriers have to take any precautions for tumors? I think no more than normal population at the moment. There is absolutely nothing more to say. Can carrier be donor if they are perfect match? Does it matter if the mutation is one that correlates? Actually, the only thing I will check on will be the inversion of the expression, but not. And actually, the mother is not always the better donor. So. And can carrier donate blood if they are healthy and platelets and bone marrow donor? The only limit here too could be the fact that they have low platelets because they are, again, with the inversion of the inactivation. And at what age should we begin conversation with our daughter about potential of them being a carrier, and how should we approach this? This depends on what one chooses to do, and if there is an hospital who is a clinician who can help you with that and can, let's say, make this flow cytometric analysis and check whether there could be any problem with the health or not. Otherwise, the normal rules say that when they enter fertility age, they can, with the consent of the mother and father, could be analyzed genetically for being carrier. Thank you.
Great. So it's really a privilege for me to be here today and to learn from so many of you parents and patients, as well as the physicians who care for the Wiskott patients. What I'd like to do today is to talk a little bit about gene editing and how it may be a method that in years to come can be applied for therapy of Wiskott-Aldrich syndrome. And what I'm showing here on, let me just see how I can get this. Let's see. Okay, very good. So what I've shown on this diagram here are really at least 4 different approaches for trying to genetically modify the chromosomal DNA of cells, blood cells, that are affected with the Wiskott-Aldrich syndrome gene mutations. And what I've shown over here on the left is essentially the outline of the structure of the Wiskott-Aldrich syndrome gene. And these black highlighted rectangles are really the regions of the gene that encode for the protein, the functional part of Wiskott-Aldrich syndrome, the protein. And just shown here in the red star, for example, is a mutation present in exon 10. It could be a stop mutation, it could be an insertion, for example. And shown on the right-hand side here is essentially the approach that's been taken first in the retroviral and the lentiviral gene therapies, where the idea is one leaves untouched the mutant allele, and one introduces somewhere at a semi-random integration within chromosomal DNA elsewhere, essentially in this case, it's a viral vector which encodes for the correct Wiskott-Aldrich syndrome gene, the cDNA. In this case, there's a promoter, and as talked yesterday about the various trials in Milan and Boston and London and Paris. Essentially what's been done is to use the 1.5 kilobases, 1,500 base pairs that are normally found upstream here of the Wiskott-Aldrich gene, and sort of encoded here to try to confer some regulated expression of the gene. And this essentially introduces randomly, and what we saw yesterday is depending upon the titer or the amount of virus used, there can be anywhere between 0 up to maybe 3 to 4 copy genomes per cell of this targeted construct. And the wonderful thing is that at least since 2012, 2013, is that in fact this method works, that we now have patients who have received bone marrow or mobilized peripheral blood CD34 cells that were treated with these randomly integrating lentiviral vectors that actually restore some level of Wiskott-Aldrich syndrome protein and actually have immunological reconstitution. We saw data yesterday that's saying the level of benefit depends upon how many genome copies there are per cell and how many CD34 cells that are delivered to patient. But I think that's actually already quite an improvement in terms of the gene therapy field. What I'd like to talk about today is really recent methodologies that other groups and our own have been developing, using ways to try to target the integrating DNA into specific sites in the genome with the idea of actually correcting the mutation. The difficulty with the random integration is that one doesn't really know whether one's going to end up in an expressed or a silent region of the chromosomal DNA that'll influence how much of the protein is produced. There are also potential issues in the future. We saw that in the retroviral therapy. So far, the lentiviral has been very, very clean, but essentially, when one looks at the number of different integration sites in a treated patient, there can be anywhere between 10,000 up to 20,000 unique integration sites. And again, fortunately, the way that these vectors are designed, they're much, much safer than those previously. So that's really an encouragement compared with the original Hanover trial. What I'd like to do is to talk about the method, for instance, the one on the second line here is where you still have the mutation present in the Wiskott-Aldrich syndrome gene, but in this case you take a region of the genome that you know to be essentially safe for incorporating new genetic material. We call it a safe harbor. And essentially by targeting the gene together with the promoter specifically into that region, one can better control essentially the level of expression of the gene, because it's always the same chromosomal environment, as well as one can minimize the potential off-target insertion mutagenesis potentially leading to cancer at some point. Shown in the third line is what we mean by site-specific correction. And that's a case where we very specifically, almost the same way that you would with your word processor when you do a spell check and you identify there's a region that you have a misspelled word, you sort of go in with your mouse and you highlight the misspelled word and then replace it essentially with the correct spelling. And that's what's being done more and more now, where essentially one can maintain the integrity of the whole genome structure for the Wiskott-Aldrich syndrome, but very site-specifically correct. And I'll talk a little bit more about how we accomplish that. Finally, the last approach that we call targeted endogenous integration is really one where we take essentially a region of the Wiskott-Aldrich syndrome gene and we target essentially, in this case, what we call intron 1, the remainder of the protein coding sequences, but now normal, not having the mutation in exon 10, but rather being wild type, with the hope being that by targeting into that region there, that we're able to benefit from the normal expression configuration and proteins that normally regulate WASP protein expression to try to retain both a safe as well as a good level of physiologically regulated expression. And I'll show you an example that we believe that we've been able to accomplish that. So how do we accomplish essentially lines 2, 3, and 4, that is very site-specific, either integration or correction? And basically what's shown is up above is what we call a nuclease. This is the sequence-specific targeting where you essentially, almost like a scissors, cut the double-stranded DNA and therefore recruit into that region of the chromosomal DNA all the normal repair machinery that's usually involved in repairing mutations that we normally encounter exposed to various types of chemicals or radiation. And there are 3 possible consequences of when we introduce that double-stranded break. The one shown on the right here was essentially one where you don't provide any kind of DNA template or DNA donor. So you basically cut, and the cell machinery tries to bring those 2 ends of the chromosome back together, and essentially annealing or sort of healing that. But this is a very error-prone process. So in the absence of some kind of DNA donor or DNA repair matrix, essentially there's frequently some kind of introduced mutations, either a small deletion or insertion or mutation at that point, which is actually useful in a number of systems, but is, for what we're trying to accomplish here, is typically an undesired event. What we're typically trying to do is by determining the DNA repair matrix, either in the one case where we have essentially a very small change. For instance, let's say up above we were targeting cutting at the mutation, then down here in the DNA repair matrix, everything is in blue except this little area of gray or purple I can't quite see. But let's say that's the normal base pair. Let's say that's what was supposed to be there. So where you may have had a stop mutation in the mutant, in this case we may have the correct base. And the idea is to essentially replace and end up what we call gene repair. That was corresponding to the third line where we had the gene correction. And then finally, the final one on the left is you see a large amount of blue. That's actually a larger piece of corrective DNA. Could be those cDNA for exons 2 through 12, where we actually try to incorporate that well. So basically the kind of correction we're trying to obtain, either safe harbor or gene repair or targeted endogenous integration, all relies on the delivery of a nuclease as well as a DNA molecule. So how do we accomplish these sequence-specific DNA break? And it turns out that there are at least 4 types of molecules that I'm aware of right now, but the first three are all sort of based generally on this idea, which is essentially protein, this ZFNR, is zinc finger nuclease, the right arm and the left arm. These are essentially types of zinc finger motifs, sort of protein type motifs that have very specific recognition for DNA sequences, in this case on either side of where one's going to introduce a double-stranded DNA break. And in fact, many of the proteins that we have in our body that are involved in turning genes on or turning genes off all have this kind of zinc finger motif, so they're used quite prominently in affecting the expression of genes within our body. But what's done here is essentially to create a chimeric protein where you take these DNA binding protein motifs and you link it to FOC1, which is essentially a region of an endonuclease, something that cuts DNA. So the idea is when you have the binding of the two proteins to the double-stranded DNA, those FOC1 domains dimerize and they cut right there. They introduce a very specific double-stranded break. There are two other classes of these proteins called meganucleases or talons, which all have the same behavior, essentially protein DNA recognition to accomplish a very specific DNA break. What you're perhaps familiar with just following the literature, there's been a tremendous revolution in the last 3 to 5 years using a new methodology which is very easily adaptable in laboratories and hopefully will be useful therapeutically as well, where now our double-stranded DNA up here has a target sequence. And what we're using here for recognition is not a protein, but rather an RNA, simply another form of nucleic acid that, almost like a zipper, a Velcro approach, is going to bind to and specifically recognize the target sequence, and then this Cas9 protein just introduces double-stranded break. So many of us in the field, we use all three or all four approaches depending upon what we're trying to do. The main thing is the introduction of a very specific double-stranded DNA break, which I'll come back to. So in terms of when we think about sort of Wiskott-Aldrich syndrome, we think about, well, which methodology do we want to use? Now, I won't talk about today. There's some potential for using this non-homologous end joining or this error-prone approach for certain mutations, but in general, what we wish to do is to deliver some kind of DNA matrix, either for very site-specific DNA correction or to introduce DNA. And this is a schematic that's been shown previously, showing that if we have, I think this was in fact 140 patients that were examined for a number of mutations. And what you can see is that in fact there are mutations present across the genome. And so it is in fact possible to develop very specific reagents to correct any of these mutations. But in fact, the approach that we've taken is to try to come up with a methodology shown in the lower panel, which is in fact capable of correcting, in this case, all of the mutations that may be present in exons 2 down through 12. So, but that doesn't preclude the fact that for very more common mutations, one can in fact look at utilizing the site-specific correction. Okay? So in order to do this, what we would think of doing is, let's say what we're showing here is in fact the WAS gene in, let's say, a CD34 positive cell, the same way that would be obtained from either bone marrow or mobilized peripheral blood or cord blood. And the idea is to very site-specifically introduce the double-stranded break, in this case in a non-coding region, and I'll come back to that, in intron 1, and then essentially try to utilize the remainder of the correcting sequences that WAS 2 through 12 with these flanking sequences that essentially provide for an ability to undergo essentially a targeted integration of the sequence. So this is what we would ideally look at using for therapeutic purposes. What we've done just in some initial studies with a primary CD34 cells is in fact just replaced that transgene with essentially a fluorescent reporter that just allows us to then monitor the success of our targeting into the CD34 positive stem progenitor cell. So the idea is we're going to introduce, in this case, the zinc finger nucleases, and we use sort of electric shock to the cells to introduce messenger RNA that encodes. We deliver the viral donor, in this case, through a virus called adeno-associated virus, and then we basically then analyze the cells thus afterwards. And just shown here is what you see is if on the right-hand side, we're just analyzing the cells 3 or 5 days after we've delivered the zinc finger nuclease at the nuclease together with the donor. Shown on the right-hand panel is just what happens when you don't have any nuclease. You just deliver the donor itself. So you see very, very little, essentially green dots. But if you look then on the left-hand panels at day 3 and day 5, you can see that by day 5 we have approximately 10% of the cells that are now expressing this green fluorescent protein that's evident for the target integration. And in fact, when we've gone ahead and looked at the cells and grown out colonies, that I think 95% of the cells give rise to colonies, in fact, have targeted exactly in the right location. Now, this is a complicated slide. I just want to draw 2 points of interest. The first is this shows starting from this HSC or hematopoietic stem cell, you can see how that cell, in fact, through a number of stages of differentiation, specification, ultimately gives rise to all the blood cells at the bottom. And typically what we're using for, let's say, stem cell transplantation is the total CD34 positive population, which is basically the upper 2/3 or so of the cell types shown. Okay? But ultimately, what you really require for long-term, stable, multi-lineage reconstitution in the patients is really that hematopoietic stem cell. So even though we do most of our analysis simply on the total CD34 positive population, really what you want for long-term engraftment of both the myeloid and the T cells and the B cells, whatever, is you want successful correction in that hematopoietic stem cell. Let me also point out, I'll come back to, on this proliferative index here, what this is just showing is that the further down the cells proceed in their differentiation, they actually divide more. Okay? They're actually more highly proliferative, where the true stem cells are actually typically in a quiescent state. And it turns out that this process of incorporating the delivered DNA, either for gene repair or for target integration, requires the stem cells to actually be in a proliferative state. So it turns out that one has to sort of go through certain manipulations in the laboratory and eventually in clinical therapy that to accomplish this homology-directed repair or specific gene editing, that we need to somehow sort of increase the percentage of those HSCs that are in culture. And this just shows here that when we take the total CD30, the green cells that you see here are essentially those that are lighting up for this GFP reporter. And shown on the left-hand panel is CD34, so we're essentially going to gate on those populations that are clearly CD34. And what we then do is we subdivide them into those different categories based upon their immaturity. And really the cells that we're most interested in are those here that are 34 positive, that are CD133 positive, that are CD90 positive. And what you can see is here is, at least in this experiment, that when we look at the total committed CD34 cells, that we have about 36% cells being marked with the GFP. And fortunately, in this experiment, we still have a pretty good labeling going on in the most primitive populations that one would have to functionally test then for in vivo capability. So the current challenges right now to gene editing of hematopoietic stem cells, and these are not unique specifically to WAS. There are groups that I'll talk about trying to do this for X-linked SCID, chronic granulomatous disease, sickle cell anemia, there are thalassemia, a variety of things. The major challenges right now is a relative inefficiency of gene editing in the hematopoietic stem cells. Okay. It turns out that one can get pretty good levels in the CD34 cells, the broader group of stem progenitors, but we really need better methods for gene editing in the HSCs. And what it suggests is we may need, for certain diseases, selection for the successfully edited cells before we put them back in the patient. The second thing, and I think this is going to be as big a challenge as any, is that what's clearly been seen from the prior gene therapy trials, from Milan or from London, for example, is that in order to get good levels of engraftment with gene-modified cells, one has to deliver a specific certain number of CD34 cells back to the patients, usually somewhere between 3 to 15 times 10 to the 6 per kilogram, depending upon who's doing this. So the question is going to be here is, can we in fact, with the manipulations that we're doing, achieve a sufficient number of these gene-edited cells for transplantation? There are some methods that people are exploring to try to expand the cells while retaining the hematopoietic stem cell activity in vitro. The final thing that I would point out is one needs really ways of doing in-depth interrogation or high-sensitivity measures of these treated cells for potential off-target and on-target mutational events. And let me just take you here. This is ultimately what one would ideally think about would be the consequences of the gene editing. You have essentially in the second line, essentially those cells that for one reason or another end up not being corrected. Okay, maybe they didn't cut with the nuclease, maybe the donor didn't get in, but essentially what one would think about is delivering back to the patient population of cells, some percentage of which are uncorrected, and one population here that actually experience the site-specific correction that we're talking about. But what we know is that these nucleases have at least two potential potential adverse events. The first, I would say, is that in this third line is what I would call an on-site nuclease-caused mutation. That is, if you're targeting an exon, a protein coding part of the gene, that you may in fact introduce a double-stranded break, and if there's not donor there, you may end up with a case that you simply introduce an insertion or a deletion. Okay, that's one reason why we've targeted our approach more toward an intron or a non-protein coding region, so that if we experience that, it's less likely to have an influence. Because you may have a case here where you have a missense mutation, you introduce the double-stranded break, and then the cell, in order to repair it, introduces a stop mutation or maybe other kinds of mutations that may be undesirable. The final thing, and this is something that people are beginning to explore much more now, is what we call off-target, off-site nuclease-caused mutation. Okay? It turns out that although we try to design these nucleases to be as specific as possible, that is to only cut at the targeted sequence, what we do know is that these, for instance, in the case of CRISPR-Cas9 or one can in fact see cutting at other locations in the genome. There was recently a report that came out where people were delivering these CRISPR-Cas9 reagents in vivo. They wanted to do an in vivo gene therapy approach. And when they began to look carefully, they saw that, in fact, there was a lot of this off-target cutting at sites that they weren't able to predict in advance. So it just means that goes back to sort of my point here, that we really need to have some tools that are capable of in-depth interrogation of the bulk treated cells for potential off-targets. These are not reasons not to proceed with further development of the therapies. I think it's important to sort of balance sort of the hype and the hope with essentially what are the challenges are going to be to move in the direction of therapy. Let me just take you in the final moments of sort of approach that we've been pursuing it as well. What I've described thus far is starting with these hematopoietic stem cells that one could obtain from cord blood and mobilized peripheral blood or bone marrow. But in fact, in the last decade, there's been tremendous advances in our ability to take, starting from various forms of either skin cells or blood or even hair follicles, and by using essentially a transient, what we call reprogramming, is creating stem cells called induced pluripotent stem cells that in fact have all the properties of what we previously would study as being embryonic stem cells. But this is a case where there was no embryo involved. It was simply a matter of starting with adult cells. For instance, that's one of my hair follicles there, one that still had some pigment left in it. Okay. I told the students to pick one of those so that I could show a good picture, and then basically just took that, expanded those cells, and then was able to reprogram into cells that morphologically and transcriptionally, any way we measure, basically behave the same as human embryonic stem cells. And what we know is from mouse is that those cells are able to give rise to fully developed, normal, healthy mice. Okay? And so we know that, in fact, using sort of the correct protocols in the laboratory, we're able to derive these. So how can we potentially think about using this for wasps? Well, if we take, for instance, from Wiskott patient, the skin cells that are mutant, we make the mutant iPS cells, and we can then differentiate them and use for disease modeling. Okay, we've done some of that. One can also apply the gene correction approaches that I just described for you, and then either take them and to derive mature cells for demonstrating functional correction. I'll just show you some data along those lines. But perhaps in the future, eventually use those corrected iPS cells and use them to derive stem cells that can be used for therapeutic transplantation. So the approach that we used in this publication was essentially we were again targeting intron 1, and in this case we used the WAS2 through, that is the remainder of the corrective coding sequences, but we also put in a GFP reporter. So when again these fluorescent reporters that we just sort of expose to the proper kind of light and they bright up, they look green either in the microscope or using flow cytometry. And in this case we used a patient who had a mutation in exon 10. It was a 1305 insertion G. So we obtain essentially clones of cells that can be expanded forever that now have this target integration of the WAS. And what this allows us to do is essentially compare the mutant cells with the corrected cells. And let me just draw your attention right here to panel D. Above is just showing that in fact the gene that's being expressed in these hematopoietic cells derived from the iPS cells in fact express the correcting gene. And just shown down here on the lower panel is we show that if you look at the WAS, that is if we make hematopoietic cells derived from the WAS iPS cells, there's no band there. Okay, this was a frame shift that leads to no protein. What you can see if you either look at wild-type PBMCs or you look at embryonic stem cell derived, normal derived, you can see the WAS protein. And what you can see is in the CWAS, which we mean corrected WAS, we now see expression of the WAS protein. You can probably see it's running a little bit slower. What that means is a little bit higher on that gel, and that's simply because the sequences that we used to link the WAS gene with the GFP had a little bit of residual that would explain that difference in protein mobility. And importantly, what we showed is that when we derived the cells from the corrected WAS iPS cells compared with the mutant, that we saw both a correction in NK cell production, we saw NK cell activity. In this case, the Wiskott-Aldrich T cells basically gave rise to no healthy, couldn't even produce good numbers of mature T cells in these culture, but now the CWAS line now shows repopulation or sort of development or generation of good levels of normal T cells. And we could essentially use over here, these right-hand panels, we could use GFP expression linked to the WAS to actually monitor the expression of protein in the resulting cell. So basically what we've shown in this particular study is that by targeting that correcting gene into intron 1, we can in fact generate healthy blood cells that express normal levels of WAS, and that therefore could potentially be used if we could somehow make hematopoietic stem cells from them, could potentially be used for therapeutic transplantation. The problem that has existed up till now is that even though people have tried, that there's been limited success in actually being able to generate the kinds of stem cells we need for therapeutic transplantation, that is hematopoietic stem cells, from these induced pluripotent stem cells. But again, the field moves along quite rapidly. Just in May, there were 2 reports in Nature. One came out of George Daly's group at Harvard, where they reported that if sort of transient expression of certain factors in the developing hematopoietic cells could give rise to stem and progenitor cells. There was a report that came out of Rafi's lab in New York where they were able to take adult endothelium and give rise to immunocompetent hematopoietic stem cells in mouse. So I think those are just evidence that that down the road there may be potential here. The one advantage of doing this IPS model, I would say, is because these are not a bulk-treated population, but rather clonal. What I mean by that is every cell in that particular colony or in our expanded plates is derived from the same cell. It means we're actually able to do very, very extensive genetic assessment of whether our manipulation, our nucleases, or our targeting has caused any adverse events. And we use all kinds of things, whole exome sequencing, whole genome. We have ways of actually carefully interrogating the kind of clonal population that we're not able to do for the CD34 cells. So let me just end with the questions that were raised. Can this be used to correct each mutation? Well, in fact, it is possible using, let's say, CRISPR-Cas9, or one can in fact sort of target potentially each mutation and correct. I think there are certain problems in that if the mutations are located within exons, one can, in the process of trying to correct, can in fact introduce other mutations that we don't know what the effect will be. I think there's also the issue that typically when you take a therapy forward, that the idea of having to go through a careful sort of IND and approval of every single set of reagents that you may want to use for each mutation is in many cases prohibitive. I think that's why there's sort of a leaning toward trying to come up with therapeutic approaches that may be able to be used across a number of mutations all at one time. And I would say that our group is not the only one that's trying to apply these nuclease-targeted gene therapy. In Seattle, there's Dr. David Rawlings and Scharenberg who are working on a methodology. Adrian Thrasher's group is working to try to also, so we're not alone in this process. The second is what diseases are currently being treated, how effective it is, how safe. I would say that to my knowledge, and maybe one of the other people in the lab can, or in the audience can update, I think that although there are dramatic advances being made now, I think right now that where we have clearest evidence for use is sort of in mouse models. And people are now beginning to do preclinical trials in human cells for various diseases. I think where we may see where I know that at least the immune deficiencies where there's been the most advance made is the group out of Milan, Pietro Genovese and Luigi Naldini. They've been particularly working in the area of X-linked SCID and have made significant advances in targeting CD34 cells. I think in the area of chronic granulomatous disease, Harry Malik at the NIH is advancing that both in terms of gene repair and targeted gene addition. What are the risks involved with gene editing? I think most of them have to do with these potential either on-target or off-target mutations. And that's something that we're going to need to better know how to analyze sensitively. And I think in terms of using CRISPR for WAS or how far from patient trials, I think that, I don't know, Hans, do you have any idea for David Rawlings' work and Sharm? Do you have any feeling for timing for when we may be able to see some of those move into the clinic?
Way down, we are first quantified
Yeah. Yes.
But WASP is on the
Yes. Yes. Yes, exactly.
that works very well in the way you described it.
Yes. Yes.
I think it will be quite a few years.
Exactly. Exactly. I think in the case of WAS2, in the case of WAS, I think that because if there were not a gene therapy approach that currently was showing benefit at all these different centers, I think that the barrier for entry may be lower. I think now that there's already something that's having success, I think that the criteria that will be required for us to be able to move something like this forward will be a little bit higher. We'll have to be able to clearly demonstrate some advantage. Now, one can make a theoretical advantage and say it's better to only target one region rather than having 15 or 20,000 different integration sites. But if those integration sites are not showing, any difficulties in the children who've received those, then, the argument is a little bit tougher to make. So there's that. What I'd finally like to say is that, the work I've described thus far is really in terms of what I will call intentional or directed gene editing. If we really think about what we have in terms of a revertant somatic mosaicism that's been referred to by several speakers here today, that's really a form of gene editing as well. It's just that this is something that occurs in the context of sort of randomly introduced mutations that occurs up in some population of cells. It could be thymic precursors, could be in T cells or B cells, and when there's a selective advantage. So it does suggest that that our cells delivered to patients, at least in the right lineages, would probably accumulate in that way. And finally, just like to acknowledge my collaborators and colleagues in Houston, at Sangamo Biosciences, in University of Ghent, Belgium, and Fabio Candati. So thank you.
Thank you. It was very interesting. Just a small question about it also regards the safety, but all these non-coding regions, these introns, might have very important information like microRNAs and things like that. So do you have any information about what's in it, and are these regions, will they still be coded when you enter these insertion, or do you know anything? Have you done it? I mean, it's out there. It's just
sure. I think the point that you're making is really important, that some of these areas that we thought previously to be junk or irrelevant, in fact, have important information. I think in the case of Wiskott-Aldrich, we did not know a priori, before we did the study in the iPS cells, whether targeting intron 1 would have any adverse effect. But in fact, it does not appear to. We seem to get normal expression. The level of protein, we know better the level of messenger RNA expression and protein across the different lineages replicates that in essentially normal cells. Or when we look at, let's say, wild type cells and differentiate them. So we've not seen any loss of information. One of the things that we think that may be an advantage, sort of targeting and either correcting or targeting the endogenous locus, is that is particularly this issue with respect to getting good levels of expression in platelets. That is protein, that there's been some, that 1.6 kilobases of promoter that's used in the viral vectors now, there have been reports by others that said that actually they're important regulatory elements, DNA sequences that control expression further upstream that are required for myeloid cells. So by us planting an intron 1, at least we would in principle benefit from those sequences as well.
Yeah, but I was talking about the information within the introns.
Yes.
You know
yes.
what they code.
I know that for some genes, introns contain very valuable information, including enhancers and regulating. All I'm just saying from an experimental point of view, when we targeted intron 1, we did not see any adverse effects upon gene expression. So we feel safe in targeting.
I mean, what genes? It depends on what you looked for, because did you look for example, microRNAs or other things?
Our only concern was upon essentially the appropriate expression level of the protein and the protein function.
The WAS or
WAS, and we were only targeting WAS. So yeah.
But it could affect also other genes. Other proteins.
I guess it's conceivable, but I don't know how much evidence there is that sort of. I mean, I know in the beta globin locus, there's evidence that DNA sequences here can greatly affect sort of the expression of other genes within that locus. But in terms of WAS, in terms of influencing other,
I'll come back.
Yeah.
Thank you.
That would be the same for all gene addition strategies, right? Because if anything that inserts in the genome would have some kind of those complications.
Yes.
So one question that always bothers me
Yes.
is you still have the mutated gene behind your insertion.
Yes, yes.
And how strictly is the border, the inactivation of that abnormal gene that you have in tandem?
Yes, it's a great point. When we looked, we were concerned to what extent that if we introduced, let's say we had this construct here, this is the final construct here, we were concerned to what extent could intron 1 sort of jump over in splicing to exon 2 and give rise to expression of the mutant RNA. And when we looked by either by quantitative RT-PCR or by DNA sequencing, we saw no evidence for expression, transcription of the mutant. Yes. I mean, the point I think that also is very important here is that, you know, in these other approaches where one has integration elsewhere, there's always the possibility that not a stop codon, but some kind of mutant protein here can sort of overwhelm the corrective potential of the corrective DNA, like where you have a dominant mutation or active mutation. So we think at least if we target upstream and we have a good splice acceptor, we think we're okay there. Yeah.
And in some other genes, it's very important to have control so it's not over.
Yes, exactly. 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 So that's one reason. I mean, that's one reason why we sort of favor targeting right into the endogenous locus and not using a new promoter, but just relying upon how WAS is normally expressed in that cell.
Good afternoon. I'm Jordan Orange. I'm from Texas Children's Hospital in Houston, and it's a delight to be invited here to be able to share with you some of our ongoing work. And this is now an old story. So this is, and what we just heard about is really new and exciting, and so much of the other work being shared today is this is really just kind of an update on something that's been going around for a while. But with that said, there's some new information to share, and delighted to be able to do so. I guess everybody in this room, by definition, has their Wiskott story, if you will, and sort of what's everybody's story. Well, just and maybe that's perhaps the most important thing that brings us all together. So what's my story? I didn't know anything about Wiskott-Aldrich syndrome, and I started my fellowship in immunology at Boston Children's Hospital, and this was a time where new patients who came into the program were generally assigned to different fellows, and I had a patient who was assigned to me and ended up having fairly advanced and significant Wiskott-Aldrich syndrome, which, as I learned, was really unusual where I was. I was at Boston Children's Hospital. And in fact, pretty much all of those patients got assigned very specifically to Dr. Rosen, to Fred Rosen. But I didn't know any better, and I was just doing what I was doing. And then I went to go do my postdoctoral fellowship while I was in Boston, and I was working in the laboratory of somebody called Jack Strominger, who had really done a lot to discover what was known then as the immunological synapse in natural killer cells, which is the interface formed between the natural killer cell and the cell it's trying to destroy. And I was assigned a project and was working on that, something I was very interested in. Project was going miserably, but just because I was learning some new things, I had really done some studying of my Wiskott-Aldrich patient, and this was something really exciting that was just happening on the side while my primary project was failing. In fact, it ended up becoming my primary project, and eventually this became known to some of the people at Children's Hospital, and it was told to me that, well, you need to go talk to Dr. Rosen, because nobody works on Wiskott-Aldrich syndrome unless Dr. Rosen approves of it. Well, this was a very nervous moment for me, because I went to his office in the Center for Blood Research, and he had a cigar in his mouth, and fine furniture all over the office. And I went through my presentation, and for those of you that knew him, he didn't exactly give the most positive feedback through his body language, and he was discriminating and listening, and then asked me a few questions, at which point he said, this is really useful work. And he approved and allowed me to continue to do that, and I've been working on the cytoskeleton as taught to me by Wiskott-Aldrich syndrome and natural killer cells ever since. One of the things that we learned, though, was this, and this was from my first paper on the subject, which was published while I was in Jack Strominger's lab, which was that our patients with Wiskott-Aldrich syndrome had defective natural killer cells. And this is shown right here. And it was a little hard to get at. It was hard to get at for two reasons. One, patients with Wiskott-Aldrich syndrome generally have a lot of natural killer cells, so you have to look at them by themselves. The second reason that this was really hard to get at was that most people at the time who were studying natural killer cells would take them out and put them in a dish and allow them to expand a little bit before studying, because it was easier because you had more of them. We did some of that too. But what I had noticed is when we expanded them in the dish, they were totally normal. But when you took them right out of the patient, they were abnormal, like this. Why should we care about it? Well, and one of the reasons I was interested in studying the natural killer cells from these patients is because of what they do. They fight viral infections, and they fight cancers. And as we now know, they participate also in control of autoimmunity. It was compelling to me, at the time at least anyway, that so many Wiskott-Aldrich syndrome boys have problems with herpes viruses and other related viruses. And of course we know about the unusual malignancies that trouble these boys as well. And I thought that maybe there was some role for natural killer cells, and just began moving in that direction. Here's just an example of a human normal natural killer cell, and here's a virus-infected cell in green. And what will happen is that natural killer cell finds that virus-infected cell, sits down on it, and can kill it, and that green dye disappears, and now a vital dye, shown here in orange, can enter, marking that cell as dead. And this is what they do. And in the, this was not the first, but the second study we did in Wiskott-Aldrich syndrome, showing that, as we just so eloquently heard, what the Wiskott-Aldrich syndrome protein does is reorganize the actin cytoskeleton, and this is a normal actin cytoskeleton, admittedly and embarrassingly with the technology we were using almost 20 years ago, to show the actin cytoskeleton in a natural killer cell. And here's from one of the boys with Wiskott-Aldrich syndrome straight out of his blood. And you can see it's a not robust accumulation of actin at the interface with the tumor cell, shown below, the big one. And this was something, again, continued to work on for a while. Also, just as a case in point, as we all know, gene therapy can be highly effective in Wiskott-Aldrich syndrome. But what are the measurements that show it's effective? And one of the key measurements in both published gene therapy trials, as well as some others that will be forthcoming, is that natural killer cells can be corrected. And this was, from the Alessandro Aiuti study and our collaboration with him, basically showing that the actin, as shown in red, can be corrected by the presence of the normal WAS gene, whereas cells from these patients that, because not all of them got gene correction in their NK cells, didn't have the accumulation. And so this was one of the metrics that was put into both of these papers as evidence of gene correction. Now, does this really matter to patients? We don't know that, but I'll kind of share at least some of my own thoughts. And this, of course, is Michael here? Hey. So this is from, I think, his critically important contribution to our field, showing that disease-free survival, while we all appreciate what it's like in people with severe variants in Wiskott-Aldrich, with the mild ones that initially present as XLT, this allows for significant problems to occur at a predictable rate. And what is available to adults, quite frankly, with XLT variants that are encountering these problems, whether they be malignancy and infection at a known incidence, and of course the complications of bleeding. What's so delightful is to hear presentations like the one before mine. They give great hope, as well as new strategies in transplantation, in gene correction, and in platelet advancing therapies. And what I hope for all of the boys affected by this is a combination of things that get to the right place for the right patient. But I'll share with you the work that we've been doing. So again, doing something about infection, cancer, and autoimmunity. While thinking about natural killer cells, we thought maybe there was some way to potentially improve their activity to do something about cancer and infection. And we had made these observations and reported them in the text of our early paper, but Gigi Notarangelo and his collaborators when he was in Italy really presented this 2004 paper so very nicely, which shows that the defects in natural killer cells were corrected by the in vitro culture conditions, which included interleukin-2. And this is just a way of showing that that happened. And why did this make sense? Because the T-cell defect in Wiskott-Aldrich syndrome, really shown here in an older, in a subsequent paper, really patients don't make interleukin-2 very well. And interleukin-2 is a factor made by T cells that can stimulate NK cells in other parts of the immune system. And importantly, this was also present and distinguishable in XLT patients. So there's this relative inability to make the stimulatory factor interleukin-2, and that exposing natural killer cells to it could improve their function. And that, we got into defining the mechanism of that in 2011 in this paper. And what we learned, and I'll just summarize that, is that typically Wiskott-Aldrich syndrome protein, as denoted by the complex we just heard about in blue, after stimulation of an activating receptor in a natural killer cell, this might be triggered by a viral infected cell like the one I showed you, allows for assembly of the actin cytoskeleton as directed by WASP. And of course, if you're missing WASP, you're going to get that signal and you're not going to have actin organization. But what we learned is that if you're able to stimulate with interleukin-2, that natural killer cell, that you can induce an actin organization pathway that is generally not active in natural killer cells. It is active in T cells, which is wave 2. And IL-2 can induce wave 2 function to get back to actin organization. And then when you get your activating receptor signal, that you can get more actin organization and attack what you're trying to attack. Is this useful in T cells? Again, maybe, don't know. What is interleukin-2? Well, it's a T-cell stimulatory cytokine. It can activate NK cells to mediate their function. It can also, as we've learned long since we started doing any of this, that it's the key factor for expanding and upregulating regulatory T cells, which are critical in controlling autoimmunity, which of course is a problem in our boys. High-dose IL-2 therapy is an approved therapeutic for certain types of cancer. And so, in thinking about IL-2 in the context of Wiskott, it was not a novel concept. It was actually done by some folks in Japan in 1993 for a boy with Wiskott who had severe herpes skin infections. And he was treated with IL-2, and it helped him, and he got better. And so that was really interesting to us, and there really hadn't been anything more done to it. But I think what we've potentially stumbled upon is some mechanism as to why that might happen. And so, of course, you've heard me talk about this before. It got us to proposing this clinical trial, potentially to advance IL-2 in the context of Wiskott-Aldrich syndrome as administered by subcutaneous injection. And we started this, and we really didn't have funding to do it. But was able to get some pilot funding to assemble the study and study a single patient in concert with a clinical fellow who was working with me to advance it. And we did that, and we did some of the work in the lab. And then we got some more pilot funding to include 2 more patients. And then we're fortunate enough to get a rare disease grant from the FDA as an R01 program to complete a phase 1 clinical trial. The FDA was really clear with us that they wanted us to do a phase 1 clinical trial, specifically because they were unclear as to what the safety profile would be of IL-2 in the context of Wiskott-Aldrich syndrome. And I will tell everybody that this has been a really humbling experience to learn about the clinical trial process and how to move into a very rare condition. And I think there was a lot of wisdom in what the FDA said, but it was a ton of work. And again, if you've heard, I probably started talking about this in 2007, which is when we, I think, approached our first patient. I think that's when we get the IND to get this done. Required a lot of collaboration with a lot of people. Thankfully, one of the companies that owned IL-2 gave us the rights to cross-file with their data to help get our investigational new drug from the FDA. If they didn't make that data available to us, we would never be able to do this. But here I'm talking to you now 10 years later. That's again pretty humbling. I never imagined that it would take this long. But the idea was to do a phase 1 clinical trial to determine the safety and tolerability of IL-2 in Wiskott-Aldrich. And the secondary endpoints were NK cell function and cytoskeletal organization. And then while we were doing this study, we learned a lot more. We learned about T regulatory cells. We learned about other things, and we tried to collect as much information as possible. This was the study design. We had to do include 9 patients. There was a screening, a first treatment. We did 5 injections of 500,000 units per meter square of IL-2 per day, and there was an escalation programmed in so that after 3 patients the dose would increase and double. But there were 3 treatments separated by 8 weeks each, and this was based upon literature that had been shown in other disease settings to stimulate natural killer cells, as well as some extrapolated data from what we learned by stimulating the cells in the dish. I'm pleased to share with everybody that we finished the trial, and it was published recently in the journal Clinical Immunology, as shown here. All of those listed on the paper were physicians who worked with us and were entrusting of their patients to this study. And while we can't make the patients themselves authors, if we could, I would, because again, they were all intimate collaborators in trying to understand this and whether it might be useful, and importantly, as part of the phase 1 clinical trial, safe. So here were what were our inclusion criteria, and again, this is all in the paper, which can be found online. I'd be happy to email it to anybody. But you had to be over 2 years old. You had to have a certain weight. You had to have. You couldn't have autoimmunity, and that was maybe for some bad reasons up front. And then, of course, informed consent. And then the exclusion, you couldn't be planned to have a transplant. So again, mostly milder types of patients. You couldn't have grade 5. You couldn't have a known reaction to IL-2. You couldn't have medications that could damage organ systems that could interact potentially with IL-2. You couldn't be taking systemic corticosteroids. You couldn't be on interferon alpha. You couldn't be on any other investigational drug within the last 30 days, which was a huge problem for us because so many patients were involved with other clinical trials, and it was really hard to find anybody. And then you couldn't have a liver defect or a brain abnormality. And so, again, this was it was really hard for us to enroll 9 patients, but fortunately, and thank you to all of them, that it was completed. And these were the 9 patients that were enrolled in the study. And here are the different gene variants that they had and some of the issues specific to them. as well as some other features. And I won't talk about eczema, but we did study eczema, and we were able to, through the grant, obtain a epicutaneous water loss monitor, which is a device that we've all kind of enjoyed measuring our own epicutaneous water loss. It's this little thing, you put it on your skin, and it measures how much water passes through your skin instantly, and you're supposed to do it at 10 places on your body, and we all enjoyed comparing who had the driest skin. But it was a really nice way to objectively quantitate any effect on eczema. So here's the kind of whole story, if you will. We ended up screening 21. We ended up enrolling 9 as we had to complete the trial. We went to the low dose initially, and there was kind of one patient who stopped the low dose because they had an asthma flare requiring oral steroids, but 5 completed that. We did, after completing the first 3 patients on the low dose, go to the mid dose, and we ended up treating 3 patients with the mid dose. One of them did fine, but 2 of them had some thrombocytopenia, and we stopped, and we actually got advice from the FDA to go back and only do the low dose, which again was a surprise, not something we would have predicted from any other disease in which IL-2 has been used. And so there were no patients that received the higher dose, which again in the scheme of IL-2 is a very low dose for IL-2 treatment. These were the adverse effects that we saw in patients, kind of all adverse effects. And again, listed, there were, the most common things were, some headaches, muscle aches, fever, and these were not necessarily related to the injections themselves. These were just all comers. This was the one thing that was consistently related to the injections, was injection site reactions, and here were some of the injection site reactions to IL-2. And so results. So here was the sort of most kind of striking and surprising feature, and we didn't expect this, which was that the patients that completed the injections at the end of the study had significantly higher platelet counts, and again. It's easy to speculate on things when you look back, but this is not something we expected. So the mean platelet count in our patients beforehand was 45, and the mean platelet count afterwards was 68. And here is the baseline and end of study results in all the patients that completed the study on that dose. And you can speculate why would this happen? So IL-2 is not going to act on platelets directly. But IL-2, as I'll show you, can potentially act on some of the immunoregulatory cells in the body. And why thrombocytopenia exists in Wiskott? Well, there's the inherent platelet defects, but then, of course, we all believe that autoimmunity contributes, and perhaps this has something to do with that, but we don't know. And I'll just speculate further by sharing some of the immune endpoints that have been published, and then we have lots that haven't been published yet, but that, as I mentioned, T regulatory cells, which we didn't know about in Wiskott-Aldrich prior to starting all of this, really utilize IL-2 for their main expansion, and that at the bottom line is at the end of study, patients had higher Tregs than they did at the beginning of the study. And that, to us might speak that maybe there's some utility to this in contributing to better control of dysregulated immunity. But again, we've got no other proof or evidence. I will mention that that's kind of just an example in kind of a single case of showing that the regulatory T cells, how they went up in this individual after that treatment. I think probably safe to leave it there. We have some immune endpoints for NK cells. We haven't published these yet, but there were these statistically significant increases in NK cells, predictably. In fact, when you look back at it after the treatments, it lasts a little bit longer than one might expect. We've done the studies in the microscopy. That's some published stuff, but the reality is it really looks as if IL-2 is tolerated at these very low doses, and we saw these unexpected increases in platelet counts and a priori, and then while we didn't look for it a priori, it might make sense that there were some increases in T regulatory cells. Where does this fit into things? Maybe this is part of a treatment regimen, and maybe this is part of an adjunct series of things that can contribute to well-being of individuals that have not been received hematopoietic stem cell transplantation, or that may not be immediate or good candidates for gene therapy, as that's going to be a while before gene correction comes the way that it's helping and fixing everyone. To allow people to potentially navigate some of the hurdles that lay in front. Really just want to conclude by, I moved in the middle of this study, which was now over 5 years ago, to Texas Children's Hospital, shown down here, and was fortunate enough to be able to continue the study in collaboration with Children's Hospital of Philadelphia, Soma Jayanucci, who took up the site in Philadelphia, with Brenda Guafilla, who is the nurse coordinator that some of you may know, and then what we've been able to do in the laboratory, studying samples that come from the patients that were being treated in Houston. So where does this all go now? Well, again, the phase 1 study is complete. Funding is over. I think we have some interesting signal, and as the FDA lays out a process, the next step is to do a phase 2 clinical trial, and that has to occur not just at one site but across multiple sites, and it takes a lot of activation energy, but we'd really like to see if there's something worth bringing forward, and so stay tuned. Hopefully by the next time people gather, there'll be a little bit more movement of the peg, but we are working on it. With that, I'd like to thank you again for inviting me, and be happy to take any questions.
Questions?
Very nice. Thanks for sharing that data. None of your patients had very low platelets to start off with. Was that an exclusion criteria, or was that just serendipitous? Because I guess a kind of small platelet increase would be maybe very valuable in those with platelets under 20.
So an exclusion criteria was being under 20,000, and we had. It was, so maybe we made an impossible study in some ways, right? Because is that a wise thing to do, given the fact that 20,000 doesn't reflect the full array of platelets, because we're not getting those that are smaller than 5.2 femtoliters, and maybe what we're ultimately doing, and I would love to do these studies, and we didn't, is shift the size of the platelets so that we're really just accentuating those over 5.2 femtoliters. And again, I don't know, but we had one patient who was ready to start the study at the screening visit and was 22,000 like the day before. It was 19,000 the day of screening, so we couldn't do it. But we did have a few that were just above 20 in the study.
And as you envision IL-2 potentially being used, would that be a therapy that needs to continuously be given, or as somebody has an infection or a cancer, would be added to them?
Right. So thanks for that. So again, if I were to kind of dream how this might be part of the therapeutic armamentarium, it would be for a periodic series of injections to stimulate natural killer cells and expand T regulatory cells, so that it's kind of a almost a preventative, if you will, to allow the natural killer cells to have some activity to potentially eradicate abnormal B cells and to potentially eradicate reservoirs of viral infection, also to allow some T regulatory cells to expand. What is the right frequency? I don't know. Would that be every 6 months to get a series of injections? Every 3 months, but something along those lines.
No. So I have two questions. The first is, you focused your talk on NK cells and regulatory T cells, but correct me if I'm wrong, IL-2 is affecting the proliferation of all immune cells, right? So B cells, T cells, right?
Well, see, certainly T cells,
Think
most
also
importantly.
B cells.
And it can, but you have to, cells that have the IL-2 receptor.
Yeah. So my question is if you have autoimmune cells, like B cells and T cells that are autoimmune, they would also expand, wouldn't they?
So so it was something we were really worried about when we started the study, but then what we learned is that regulatory T cells have a much higher affinity for IL-2 than most other cells. And there's actually, in a number of different contexts, IL-2 can promote a preferential expansion of the regulatory cells over cells that are otherwise autoreactive. So in fact, while we started with the hypothesis that we need to worry about autoimmunity, we got more excited about the hypothesis that IL-2 would be doing a lot to control immunity. And when you look at diseases in which IL-2 is broken, so like CD25 deficiency, these patients really suffer from autoimmunity. So we started with that fear, and we ended, given some of the evidence that had come out of mice and patients, that that was actually a good thing.
So you didn't see any autoimmune manifestations in your study?
So what I can, so let me just sort of reiterate what we did find, which is that at the low dose, we found no evidence of autoimmunity, and even staying in contact with these patients long after the study was completed, in some cases years after the study, we've not kind of seen any of these things. In the patients that got that higher dose, there were 2 patients that got thrombocytopenia. So why that is, I don't know.
There was one with asthma as well.
Yeah, so asthma, it depends how you, what
allergic reaction.
Yeah, it depends what you define. Personally, personally, I think that was just his asthma, but it happened while he was on the study, so he ended up because he needed steroids. Steroids are a reason that we stopped the study.
And another question is, mostly it's for, I guess, mild WAS patients, right?
For what?
For mild WAS?
So I think so, just because the treatment options for patients with, more severe disease are certainly life-saving.
So when you look at mild WAS patients, their immunity is quite well. The only major problem is their platelets, actually. So
their only problem is their platelets until it's not. And I think that what Michael's research has shown us is that people, move along, which is why it's difficult to justify doing a transplant for somebody that's really doing kind of well as long as they don't play tackle football. But the reality is that these events pop up at some, at a almost a predictable frequency, and that's something that would be great to be able to prevent or control.
What happened when you stopped giving that? Is that any other effects?
So we and again, that's not part of the phase 1 trial, but in staying in touch with patients, we had not identified any problems that arose, and again, so far nobody's had any, nobody's had any malignancies or nobody's had any new autoimmunity. There was 2 patients in the study that, much to my chagrin, didn't like the way they felt off of the IL-2, and they actually got their physician to prescribe IL-2 for them, and so they stay on it.
Do you have any idea about kinetics?
How long, for instance, does it last to have increased FOXP3 positive Tregs, and also the platelets? The half-life of platelets, of course, is 4.5 days. So if it only works in megakaryocytes, releasing of platelets, it should disappear within a week. Do you have any feeling for that? Any data?
So we tried to publish as much of the kinetics as we had available to us in the paper. The reality is that the most profound differences were when you look from beginning to the whole end of the treatment cycle, which, in me speaks to this being an indirect mechanism, potentially through some improved function of Tregs.
It would be important for design of a new trial, because I would see that you have to give it every week.
Yeah, I mean, and this is again, if you're trying to specifically focus on platelets through that modulatory effect, maybe that's the right way to go about it. But
there is a new protocol for SLE with low dose IL-2. And you may look at that protocol. I don't know the details, but I would assume it is a continuous treatment, maybe a dose escalation, but probably on a regular basis, not these blocks of a few months and then.
Yeah, I mean, it's certainly a reasonable, again, trying to, if the objective is to get function out of Tregs, it's a reasonable way to go about it.
Because I think for mild Wiskott, this would be a very good long-term
I'm sure
treatment.
As we plan the phase 2 study, I'm sure we will beg to tap into your wisdom and anybody else who is willing to offer wisdom.
Yeah, the problem with the XLTs I have, they don't come to clinic.
Yeah.
They do so well.
Thank you.
Thank you, John.
Okay, excellent. Thank you so much for having me today, and a special thanks to the Wiskott-Aldrich Foundation for putting this on, and also to all of the amazing scientists from all over the world here today who've been dedicating their lives to this issue. I bring kind of a unique perspective to my talk today because I wear 3 different hats. So the first hat is I'm a mom of a little boy who has Wiskott-Aldrich syndrome. He's 5. He had classic WAS. So I understand being a family member. I'm also a psychiatrist, so I understand mental health issues, but I also am a physician and understand what hospitals are like and how they work and how the physicians are acculturated. And finally, I'm a scientist. I do a different kind of science. It's called health services research. So my lab isn't working in a basic lab, but it's actually looking at health systems. My health systems are my petri dishes and trying to figure out ways in which we can improve the healthcare system. So you'll see in my talk that these different perspectives are kind of weaved throughout as we together try to understand ways to better support families. I have some disclosures just about some funding, and the learning objectives basically are about us thinking about Wiskott and, again, how to support families. So here's my son and my daughter. My daughter was 4 years old when Anderson was diagnosed. And I'm going to tell you a little bit and begin with our journey because it's relevant for the discussion. So he was diagnosed when he wasn't diagnosed, but the first kind of incident that happened was during a well baby visit when he was 10 days old. He had bloody stool in his diaper. The doctor, that was the first time actually that I had seen that. The doctor sent us downstairs to the emergency room. He was found to have low platelets. The parents here know that's not a big deal because it's part of Wiskott, but in an infant his age, a lot of the doctors thought, wow, he's got an infection. They sent him to a pediatric ICU. He was poked and prodded, as many of us are used to, but it was really shocking the first time. And he was found to have an infection. And it was really great, actually, that they found the infection. It was an HSV infection, HSV-1, which neither of my husband or I have these cold sores, but I think he caught it probably from some staff when he was in the hospital as a little baby. He was in the hospital for about 3 weeks. He continued to get this IV antiviral medication, and then was released and still had the low platelets, and they didn't know what was happening, and that's when you started looking for other reasons for him to be there. And I kind of, as the diagnosis was narrowing, I knew something, was the matter. And he was diagnosed at 4 months. I remember the day very clearly. It was the day after I returned back to work, and I received the phone call that I knew was coming, but it always, it still was really heartbreaking to finally get the diagnosis. Then we began the search for a donor. So Anderson had classic Wiskott-Aldrich syndrome, so bone marrow transplant was our best option. My daughter was not a match. And we actually got a match from cord blood was the match. It was a 7 out of 8 match. It's actually a little girl from Seattle. I don't know who this person is, but we're very grateful to this little human being and the cord blood that came from her. But because of my 3-week hospitalization, I'll get into this later, I kind of had a preview into what a prolonged 2.5-month hospitalization was going to be like. And so I did a lot of preparation for that bone marrow transplant, preparation for my family, preparation for our home, how we were going to be living, how we would take care of ourselves and of our daughter. We stayed on the unit. We were treated at UCSF. So Morton Cowan, who you guys saw this morning, he was our doctor. We were so fortunate to have him. I mean, he saved my son's life. And we were there. It was only complicated by mild graft versus host disease. We were let out. We went home. Again, like any of you who've had transplants. How many people in the room actually, his little sons had transplants? Okay, so several of you. And, going home had he had a central line, NG tube, 15 meds, and all these different regimens, which, I'm a doctor, was still hard to do because normally nurses actually do that in the hospital. I didn't have to manage regimens. So it was actually really challenging to deal with that. Then we, today, thankfully, Anderson is almost 5 years post-BMT. He'll be 5 years in August. And now I'm trying to kind of leverage my unique perspective and pivot a little bit of my work towards looking at ways to better support families. One of the ways is actually I'm starting to write about this and start doing some studies. So I actually wrote about our perspective with Dr. Cowan in an article on BMJ. Again, we had a unique situation that not all families have. So I think those providers in the room know that you don't always have somebody who has a bunch of family and friends and really excellent colleagues. I could call up people in Boston and talk to them about what was going on. I could find out from child psychologists what's the best way to help my 4-year-old manage this. We're educated, English speaking, we knew the language, we had good health insurance, financial security, lived near the hospital, and again, I was a physician. So we had all these blessings, and still, as those of you who've been through it or similarly are, in the situation where you're kind of in waiting, it was very hard. So now I'm going to look at, pivot us now. So that was my story. But, I'm going to now look at some of the evidence of how does this medical trauma impact families? And most of the data, right, because we've gone through today on a few different talks, these sample sizes that are very small. So most of the data that we have about psychological impact is about the data from bone marrow transplant, not so much on Wiskott itself or on XLT. And so I know that this doesn't apply to everybody, that some of you didn't have transplant or are not planning on getting that, but I do know the stress involved with this disease, no matter how severe it is, can lead to a lot of these different sequelae. So I'm going to go through some of those things. And this, by the way, this is the Anderson and Simone. This was his first bath. It was a very meaningful evening for us. Okay, so what are the psychological impacts of BMT on patients and their siblings? Okay, there's a lot of evidence of the negative psychological impact of BMT on pediatric patients and their families. So it's true. These range. They include anxiety, depression, PTSD, and declines in health-related quality of life. Similarly, something that's been pretty interesting for me to read about, which is what I knew about kind of going in, was the risk on the siblings, the healthy siblings, the impact on them of developing PTSD, anxiety, and low self-esteem. They were worried about lack of attention from parents, lack of choice when asked to donate stem cells, which it makes sense. And then the folks that are also there are the parents, and caregivers. And as a psychiatrist, I knew this was actually very important because any pediatricians in the room know if mom's not well, the baby doesn't do well, okay? So I was thinking about this while we were going into this traumatic situation, knowing I needed to take care of my own and my husband's emotional well-being. Otherwise, both my son and daughter wouldn't do as well as they could. So it was a way to kind of enhance their resilience through this. But parental distress includes worry, concern, and guilt about the child undergoing BMT. You can replace BMT with Wiskott or splenectomy or whatever. This is your child. You're afraid of losing your child, afraid of relapse. I know now, even watching some of the slides in the presentations, thinking about, the 2 or 4% chance of malignancy, that it's just scary, to think about these different things that can happen. I don't think the Wiskott's going to come back, but I worry about these other things. Parents are worried about relocating to the transplant center, living in separate households often from one another. Lengthy hospital stays, often 4 to 6 weeks. Again, we were more like 10. Financial burden, this was from the literature that I found, but actually our hospital stay, we had a bill of $1.5 million. Thankfully, I had an HMO health insurance, so that was covered, and so I had, paid $500 out of pocket. But even if it was only $500,000, my family didn't. We're fine financially, but that's a lot of money, for families to have to spend. And then obviously dealing with medication compliance, caring for other family members. So let's say your kid has Wiskott, but your father is sick and has dementia. And other work-related changes. So there's a lot of distress. After the hospitalization, caregivers actually have a really large amount of burden, as I mentioned before, kind of managing multiple medications and different IVs, et cetera. And so what hospital systems have been doing, which has been good, is that there's, trying to reduce length of stay and overall costs. Children tend to be discharged earlier, kind of for the families to help take care of them. Sometimes you might be given a visiting nurse who comes by once a week, maybe, or twice, but most of the care is delivered by the family members, and it's a lot. And to my knowledge, there's no standard of care for providing patients with training on how to manage more of their emotional stress in dealing with this. There's a lot on training them how to clean the IV, but there's not anything on, how to deal with this really stressful situation. So again, this is kind of summarizing some of the stressors more. Before you go into transplant or whatever decision you're making, there's stress in the decision making in general. I remember asking Dr. Cowan, well, what would you do, in this situation? Because you just want to know, and many people who have XLT were wondering, well, what's the best decision? And you could see a lot of the docs, at least I was noticing them, there's no right decision in that case. And so the patients are trying to figure out an answer, and they want to know, what would you do in this situation? Help me figure this out. I know some kids have bullying issues at school. There's carrier guilt. I know that happens a lot, has been mentioned a lot on the Wiskott-Aldrich syndrome page, the Facebook, people talk about that a lot. You worry about how to take care of the patient, how to take care of your other kids, how to take care of yourself, and again, traumatic symptoms persist. And I know a question was raised about when to test your daughter, and I wonder about that myself, and a lot of people wonder about when's the right time to bring up that discussion. So again, we know that it impacts the kids, it impacts their siblings, it impacts their parents, and there's, so we know this, but there's no real, kind of not as much research as I think there could be right now addressing the challenge of delivering support given this unusual situation, right? So often a parent is physically bound on the inpatient unit for like 10 weeks and how to provide some care to them while they're in that specific situation or at home with a really ill child on isolation. So most parents don't want to leave ill child's bedside. So it's a challenge to get them care. And psychiatric care to parents in the hospital. The parent's not, at least in the U.S. system, is not an identified patient. So the parent can't be seen by the hospital staff, by a psychiatrist. You can be seen by a social worker, but is not able to be seen by a psychiatrist. So are there any solutions here? How can we best provide care. And I think that was part of my fantasy in asking you the question, had maybe they'd come up with something really wonderful to do here, in England, how was this being dealt with in some way? And so one of the questions that I did is I actually threw this out to the parents, and I said, what are some of the things that are, not so much solutions in this way, but what are things that, what were some solutions that you thought how they could be more helpful? So a couple years ago, some of you may remember this, I was about to give a talk in Grand Rounds at UCSF to some pediatricians about this. It was right after this article had come out. And so I wrote and I said, hey, do any of you guys have any, I'm talking to a bunch of pediatricians. They want to, I'd like to know what you guys think they could do better. And this is kind of more my type of research, is finding out from consumers, patient perspectives on how systems can be improved. And, again, noticing the sample sizes we've had today, a pretty large number of people wrote me back. So 36 people on one post, I never repeated it, had written me back within 24 hours. And 7 were actually within 1 hour of posting this. And I have actually a medical student who's working with me next year, and we're going to repeat this. So please stay tuned and answer a survey, because you'll be asked again for this, and we'll do more analysis on that. But the punchline is that there were 3 main recommendations that family members had for providers. And these don't seem like, mind-boggling. These are pretty straightforward, okay? So what they want is pain control. And generous use of, people call it the magic cream, right? Once I had actually used EMLA on my son before he got his, blood drawn, it was just like night and day, and so much less stressful for me and for him and for my husband. And I don't know why that's not just kind of standard of care everywhere and just kind of constantly used, because it's really, the pediatricians here need to tell me if there's something really bad in using that cream for little infants, but my understanding is not. And so that's one thing that a lot of the families were saying would really relieve their stress. Another was sleep. So this is kind of more focused on bone marrow transplant, but bone marrow transplant, there's a lot of line changing in the middle of the night. That's just something that happens, and this could be done during the day. And, there's a lot of evidence that sleep disruption lowers people's threshold for, having their mental well-being, and so it's best for us to try to do everything we can to protect sleep. So I think if systems started thinking about protecting sleep, that would really help families quite a bit. The third was just checking in on emotional well-being. Now, I think that my perspective, putting my physician's hat on, I think what happens is that some people, some providers get really worried they're going to open up Pandora's box and like all of this emotions are going to come out and they're not going to know what to do with it. That's what I think, but I might be wrong, but I have a feeling this happens sometimes. But this quote was the most telling to me. One of the people wrote back, maybe putting 10 minutes aside a week with a nurse or doctor to discuss any worries we might have. This was the patient's request, who's like living on an inpatient unit for weeks. This woman wanted 10 minutes to talk about how she felt, and that seems doable for systems. It's just how to make the system set up in ways to make it not onerous on everyone. Other recommendations that they had were rounding at the same time each day. Again, that's a systems challenge that could be very difficult to resolve because of how things work in hospitals. But respite care isn't. So just little breaks, allowing families breaks, having babysitters there so that people can go out and make sure that their child is still watched while they take a break to go for a run or go to the gym or have dinner with their loved one. And then risk-benefit discussions. A lot of the family members had real difficulty with some of the risk-benefit discussions because they felt like they were having to choose between 2 different really challenging things. And so it just came up, which is, again, a little difficult and tricky to figure out. But like I told you when I turned to Dr. Cowan and said, well, fine, but what would you do? You may ask me, what did I do? You know, how did I manage this when I was faced with my son and daughter potentially having adverse mental health outcomes? And I wanted to both make sure my son was treated the best medically and that both of them did well psychologically. I did what all of us do. I leveraged all the resources I had. So I did, as I mentioned, I talked to a lot of different doctors. I asked them questions not just about his medical treatment, but about ways in which we could protect their mental health. The big kind of take home with me was a lot about having to take care of myself and get sleep, but also about how marriages can be really impacted, and also how the children need to see both of their parents together. So what happens often when these hospitalizations happen is the parents separate and one's providing care and maybe another's providing care, but the remaining child never sees both parents together. And they said that was really important. And I haven't read that before, but I've heard it from a couple of people. So I like order and schedules. And so I made this very detailed schedule where my husband and I had 24-hour shifts. We split it up in the middle of the day. We had my mother or his mother come in the middle of the day so that we could both spend 2 hours together every day. So we actually saw each other. We also got to, because of our 24-hour shifts in the middle of the day, we saw each of our kids every day. They both experienced every day with both of their parents. My husband and I went out in the weekend for a date with our daughter. We had a 4-hour kind of play date thing with her, and friends came and took care of stuff in our home for the weeks of those difficult 10 weeks. Again, I got good sleep every other night. I tried to exercise, used medications when as appropriate. You know, I had a psychiatrist. I saw somebody. It was a very stressful situation. I encourage you all, if you're under stress like this, it's normal and okay to take medications like an SSRI or something like that. I talked in therapy about, you know, a range of emotions and feeling really fearful, feeling really angry, feeling really disappointed in family members or friends who didn't get it. And sometimes there were friends who I thought would get it, and that was very disappointing. And then something that I just have to say thanks to Sumathi for was really the community. I don't know how many of the other families feel this way, but I remember having that online community. That's an easy thing for you guys in your different systems to recommend to your Wiskott families, is joining the community, because all of a sudden you have, you know, many families and many people who understand what you're going through, who can chime in and say, oh, well, we went through that too. It's okay. It's going to pass, or you're going to get through it, or here's my kid who's five years out. And that is really helpful. I also used an online a resource called Lots of Helping Hands, which is kind of like the Caring Bridge. There's a few of these different things, but this was a way to organize a lot of people around who wanted to help you, but without kind of it invading onto you constantly, you know, without everybody asking, how's your son doing? What's happening this week? And getting 50 requests. You could send out one email to your whole community and let them know, well, he's going into transplant and 2 weeks, we're okay, here's some pictures, and people could sign up for ways to help you. So as I said, I'm kind of pivoting my work towards this, and again, I look more at systems. So I'm going to just briefly kind of describe what I'm thinking about doing. So as you notice on the top, kind of typically, people do think about parental mental well-being and the child's physical and mental well-being being interrelated. Okay, that's very well established, that these are interrelated. And often people talk about, okay, there's these biological factors and psychological factors that influence parental well-being, so let's examine those things. But there's also systems factors, and that's what I'm pretty interested in, is like, what are the low-hanging fruit here? We can't have, like how you described in the UK, how they have a psychologist on these units that sees the family. Some hospitals don't have those resources. So if they don't have those resources, what are the low-hanging fruit that we can have to take care of these families? So, I mean, you can see here, but again, basically it's around disrupted sleep. So no line changes. These are potential solutions, but these are some of the things that I kind of already know might be on the plate as possibilities. Line changes in the middle of the night, overnight trainees. I don't know if this happened to anybody, but would come in and kind of check on you. And then wake up the baby, and it just drew me, you know, they were trying to be very nice, and it was very nice that they were trying to be nice. unattended, but they were waking up the baby, and it was just unnecessary. Poor pain control, again, need protocols for anesthetics, and then basically things to address caregiver mental health. So they need to be, I think, screening family members for depression and anxiety, and doing this weekly to make sure that the family members are okay. Different communication issues, and I think a lot more attention needs to be placed on care transition. I think that there's a lot of burden that happens to families once they leave the hospital when they're already really worn out from a lung transplant. And this would be, how I kind of conceptualize it is in this pyramid, right? That most of the patients are down below. Most patients are actually very resilient, and most families are. And so most of them are fine. You just got to make sure their sleep's prioritized, some pain control, and then maybe monitor them regularly and give them some easy ways to help them, use their resources. And then some people might need a little bit of support, but they still should be monitored. And then there's ones that need a lot more support. And we need to figure out ways in which we can address people at those different levels in easy ways that it can happen in all the systems of care in ways that are not super costly. And that's it. So, basically, I'll repeat it, but those are my suggestions for the leadership in the room. And I definitely think there's some serious importance of I didn't underline this as much, but, making sure that mom or dad, if possible, get a chance to go home rather than just staying the full time in the hospital there. I think it's important to go home. So again, I hope that medical centers start implementing programs to better support caregivers of children with Wiskott, make concerted efforts to promote sleep hygiene, and help families utilize external supports to maximize resiliency, pay attention to transitions of care, and I believe a child psychologist or psychiatrist should be on patient care teams. And be attentive to parental stress and signs of mental illness. I think this would help really alleviate a lot of these problems. So that's it. Okay, and this is Anderson later. He's doing great. He's my Superman. So anyway, thanks guys.
Questions?
Thank you very much. That was great. I actually have a question about the sleeping of the parents at night. We are in a situation where we don't have any space for the parents to stay overnight, so we actually have to send them home in the evening or to the apartment next to the hospital.
Right.
And I'm constantly, when I prepare families for the transplant, I'm met with anger or fear or frustration about the fact that they cannot stay with their child overnight.
Right.
On the other hand, after the transplant, I get a lot of feedback that they really appreciated some families really appreciated that they could get some sleep and were surprised how good their kids did without them during the night. So you being a physician, you having gone through that, what's your take on that?
It's so interesting. I think that there probably are these benefits to them having that break, being able to go out and sleep on their own. I wonder how good their sleep really was sometimes, because of the worry of what's going to happen if my kid's on their own. I think that it depends on how it's all set up. If there's a nurse actually sitting by the bedside who says that they will call you immediately if something happens, that's different than if a nurse is watching 20 kids or something and doesn't always have the eye on them. So it kind of varies. I'd say for most parents that I know, they wouldn't want to leave. I think they're meeting this resistance because they don't want to leave their baby. But I think I don't know what the solution is. I don't think it's bad that they got sleep. I think it's good that they got sleep. I don't think it would make sense to set it up like that so they couldn't stay with the babies. I think more and more evidence is the more the mother's around and the closer they are and being able to touch the baby at night, the better it is for both mother and child. So I would say it would be, I see why they probably did better and felt relief. I remember when I got home from the hospital, I was like, God, it was so much easier with nurses around all the time because it's exhausting to deal with, all of the stuff. You so wanted to get home, but it was really exhausting. So they were probably also picking up, they might have attributed some of their feeling better to that. But it's, it's really interesting. That's how it works out there. It must be very hard for you and for them. Yeah.
Thank you. That was really interesting. Can I just come back to the issue of resourcing for psychology or even, I guess, a support team within the hospital? So going forward with your research, are you going to look specifically, or can you look specifically at the cost saving that could occur if families were better supported? Because if all of the research stacks up, then there should be a benefit for the family, not even within the hospital. I guess there's the benefit for potentially shorter stays of things if everybody is better off. But there's also the impact beyond the hospital on the family, employment, etc. So it must be quite I would think it must be a good question to look at from a research perspective.
Yeah, 100%. I mean, look at the cost effectiveness. I mean, my gut instinct is that it actually would reduce some of the recidivism in coming back home if they had more supports and were kind of better prepared once they leave, that you would reduce it. But definitely, that's what I'm going to be looking at, is some cost effectiveness. First step is just figuring out what I'm interested in finding out from the different BMT centers across the country, the different perspectives from the different types of staff about what some of the issues are. Because these, again, this is my construct, and also, been working with people at Dana-Farber and Sloan Kettering that are doing really cool things at those centers. They're doing, at Sloan Kettering, they do a virtual clinic and give all parents medical record numbers so that a child psychiatrist can see the parents and treat the parents. But they have a lot of resources. But yes, I'd want to find the cost effectiveness, because that's the way you buy in the other systems. So I'm an implementation dissemination scientist. I know that money is the bottom line for a lot of these health systems. They want to do a lot of good things, but if you show that it reduces costs, it'll help. Yeah.
I mean, I think just one other message from the London service. So the paediatric London service have a weekly psychosocial meeting between the social workers, the psychologists, and the medical team, and that talks through all the families. So I think it is a very good model.
Yes.
Because it does identify things that parents have maybe said to a different member of staff that otherwise might not get fed back to the medical staff.
Exactly.
In some ways, when you see the comment about what families would like is 10 minutes for somebody to talk to them, and I'm thinking, how does that not happen? Our perception as medical staff is that you spend more than 10 minutes every day with every family on the transplant unit, but maybe actually you're not addressing the issues that are very important to them.
Right. I mean, I think, a few different things are going on, but regarding the psychosocial rounds, so that would be for the physicians, is like a period of time when all of the doctors and social workers and everybody gets together and thinks only about psychosocial issues related to the families. I love that, and I think that some places do that, and it's great because it also helps teach some of the providers. I've talked to some docs who say, God, I don't even go into the room until mom's gone because she's so anxious, and that was informative to me, because I was like, wow, he doesn't know that means mom might need extra help. So if he was able to, to talk to some other people in a group like this and then say, oh, she's so anxious, I'm avoiding her, then they could say, oh, I wonder if you're avoiding her because she's really got a bad anxiety disorder or whatever, and let's go make sure that she gets has some medicine or sees a therapist or does whatever, and so I think rounds like that are very, very helpful.
Hi. So I was offered a couple of things at Stanford. They had someone come through who's a chaplain, and that was really helpful for me. They couldn't talk about my feelings about the IV or they would listen, and they were kind of like a psychologist in that way. So that was really comforting to me. And then at some point they said, do you need me to come tonight or today or whatever like that? And I would, say yes or no. And then, so that was helpful. And then after transplant, we were offered the opportunity to see a psychologist with my 2 daughters and then the transplanted son. And I went one time, and they did art therapy and things like that, which was really great. After that, I denied going, thinking that, my kids seemed pretty well adjusted to this whole process. And we also tried very hard, Christina, to do the same things that you did. Date nights, I got out and ran. I had people come and babysit him inpatient so I can get out. Spent lots of times with our family. We had them come visit. It was, we really tried hard. Okay, so now, around 5 years after transplant, my oldest daughter has really bad mental health issues right now. And I'm not sure, so she has cut from the time she was 12 to 17. And if you know what cutting is with the arm, cutting herself, self-harm. She's also been suicidal, has had depression, and now has an eating disorder. And it kind of came out of nowhere, I think. And so I wonder, should we have gone to the psychologist, at the beginning and taken more proactive approach? I thought I was doing everything right. So I don't know if her problems are related to the trauma that, she was witnessing. She has empathy. That's one of her gifts, is empathy. So I don't know. It's hard for me to determine, did I do something wrong?
Yeah, and I think that's where a lot of us go, right? Did we do something wrong? And so I don't think it's, I can't say with certainty, but I wouldn't do that to yourself. I would just kind of, it sounds like you were reading the situation right, everybody was doing well, and you did what was right for you and your family at the time. I wouldn't do that. I would say, you're a great mom, so I'm sure you're making sure she's getting treatment now and looking at it, and that you can make sure that provider knows that this had happened in your family. That's how I would approach it, but I wouldn't do blaming yourself around it. I think the one thing that I was going to mention, because you said something about, I'm going to pivot to the 10 minutes, like we spend way more time than 10 minutes. I think what probably happens, because I remember, at least from my perspective, being there, and I had my list of 30 things to ask, or 20 things, on the wall, and so there was a lot of time spent in there. But I'm saying, like, make sure one of those times that you go in, like whether it's psychosocial day rounds or the day before, that part of it is like, how are you dealing with living here? Like, how is it in here for you? Are you getting enough sleep, or are you feeling okay? This is really stressful for most families. Like, it would be unusual. I think how I see it is, it would be unusual if the person was dealing with it perfectly and had no problem, because that would be very strange, right? Child's really sick. So yeah, but in your case, Amy, no, I don't think there was anything that you did wrong that would make that happen. So.
Just a couple things. He had his transplant later. He was 5, so
your son?
A little different experience here.
Yeah.
But through chemo, I stayed with him. My husband was there as well, so I was very lucky in that matter. But after he was done with chemo, I stayed at Ronald at night and slept, and I was only there for like 5 hours, but it made an enormous...
To sleep.
Yeah, to sleep and not have the nurses, because even though you're in your own room, you hear all the doors, and you've been a light sleeper for 5 years because you're always worried about waking up and this, that, and the other thing, but back to the post-traumatic stress, living with that for so long and then going through that, the stress was more his life prior, right. I think. And then the survivor's guilt.
Mm-hmm.
Lots of friends.
Yeah.
But that's the big part. Not so much post-traumatic stress, but the survivor's guilt. I don't know.
Yeah, I think if I'm understanding you right, you mean like that other families who lose their boys. Yeah, and I remember.
And even the kids on the floor. I mean, there were
right.
There were no other Wiskott kids. You know, you lived with these families for 150 days.
Right. It's really, I think, very, very challenging to deal with. And I remember, and Sumathi knows this, there was a little boy who, a year after Anderson had his transplant, was almost identical situation, had a transplant and passed. And I went to the funeral, and it was, one of the hardest things I'd done. So I can definitely relate. I think it is different. I mean, it makes me wonder a lot about, there's a lot that goes into it, and a lot of suffering, but I'm just so happy. I mean, he's it's awesome. That's great. And sleeping, but it does make me wonder again about this sleep stuff and the different places to go. Yeah. Yeah. No, well, thank you. Thanks, I'm glad. Okay.
Thank you.
One important issue which came to my mind this morning when my colleague from Italy said that girls will not be allowed to be tested for carrier status. You brought it up with your daughter. What is your perspective, or the parents' perspective, to test 4-year-old, 5-year-old who has seen the mother going through hormone implantation for carrier status?
Yeah. Oh, what's your perspective of when I'm going to test my daughter? Is that what you mean?
What do you think?
Yeah, what I think. I mean, I wish I had the perfect answer. How I'm looking at it. This is not evidence. This is just my own perspective. Is I think that our discussions about Wiskott again will evolve over time. So now, and with my son and my daughter, she's again 4 years older, so her capacity is obviously greater than his at understanding some of this stuff. I imagine it's probably going to come out. It's better to talk about some of this stuff if it comes from them or comes out of natural conversations that you're having about stuff. So if there's like, I'm imagining like she starts to learn about biology or cells or genes or something like that, having an opportunity to kind of go in and talk about like, well, there's this, genes, and you know what genes are. Did you know that Anderson's disease was a genetic disease? I think I'm looking for those opportunities to bring that up with her. Do I? It's something that I'm afraid of. It's something that I'm not sure if I'm going to do it right, but I'm not going to do it now at 9. I'm probably going to do it when it comes up, probably more like around in the next few years, couple of years, probably 12. By 12, they have more executive function. They have a little bit more abstraction and capacity. I think I probably might start talking about some of that then. I don't think I'm going to test her without her wanting to, and I don't think it'll be more an option that I want her to drive that testing, and that it's possible for her to be, get testing. But that's just, again, this isn't, there's very limited data on this kind of stuff, and I'm not sure how to deal with that quite yet, because it really is about, she's not sick, and she's not going to be sick. It's about her having a baby, and that baby potentially having Wiskott. There was a... I'm not having kids. Right. Wow. Oh, wow. I see. Oh, wow. Yeah. But there were opportunities that it was natural within the conversation. Right. Right. I think that's the kind of part that's technology is such right now that kids are looking up all sorts of stuff, right? So I don't think my daughter's gonna like look up Wiskott. I think it's much more like that she's gonna look up, you know, all sorts of other things that I don't want her to look up too. But you know, she might be curious, and then if she looks up, she might figure it out herself. So I want to have it. You want to be able to have something where you're able to have the back and forth conversation is open and that you do that. But there's no perfect. I don't think a perfect age. I don't know. What do you tell your patients? Yeah. What? Oh my gosh. Oh my gosh. And the parents knew the whole time. Oh, they did not know. Oh my God. Right. Ramifications. Right. Yeah, that's right. Yeah, yeah. I think earlier, that's why I was saying like around 12 or a little earlier, or 11 or 12. That's when I was aiming, that's what I'm aiming for. But I think if the opportunity arises earlier, and again, it's about the kid. I'm not a child psychiatrist, so I'm an adult psychiatrist. But I think the time if it elicits from the conversation, that's a very natural time for something to be dropped. They probably will drop it or will go with it. It depends on the kid. And then you just follow their lead with it and just reassure them. Again, with your daughters, it's like, you know, the technology by the time they decide to have kids is going to be pretty different. That even now they could, you know, have it just fine through IVF. And even our boys might, who knows? In Germany, and you can't do it until they're 18. Right. 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 Exactly. Right. Child-driven, which I think would be, yeah, my gut would be child-driven, and probably it's sounding like around 11 or 12. Might be a good time, but who knows? Exactly. Right. Yeah, it'd be the earliest. Yeah, I don't know. It's very hard. I do too. Yeah. Right.
My already stressful life, like being a teenager, going through high school, everything like that, and then finding out that you have this disorder, then like having all your questions, I think personally it was easier for me to have known all along.
Right.
But yeah.
I think it's like what you're saying. I don't think there's like a right answer here. And thank you, by the way. That is very helpful for us to hear, like somebody's experience with it.
Yeah, and I think this is often the case. Mm-hmm. You know, at that time they are much more accepting things. Mm-hmm. But another wrinkle, now you have a son with Wiskott, and he has daughters.
Right.
They're all carriers, right? But some of them are not the daughters of their father. So this happened to me several times. It was a paternity question.
Oh my gosh.
And so if the daughter is not a carrier, now how do you handle this with a family?
That's for a whole other discussion. Yes, I think we're red herring, but thank you. It's a good question.